probably trickle in over time. But I'm Doug Franzen. I've been actually involved with the CDEM exam since it started in like 2007. I don't know. It was a long time ago. Very long time ago. And currently, I actually chair the group that writes that advanced clinical exam for NBME. And we got a couple actually other members of the committee in the room with us, some honored guests here. But we're going to talk about writing multiple choice questions today. And so our other guests are Navdeep Sekhan from Houston and Meredith Thompson from Florida. And the first part of this, we're going to just kind of talk about big, broad overview stuff with like how do you design a test and how do you make sure that your questions are doing what you think that they should be doing. And that'll take you not quite an hour. And then for the second part of this, there's going to be some other people joining us who have sat through this boring part before. And we're just going to go through a bunch of questions. So I ask, our more experienced question writers to submit some questions. And we're just going to basically model the process of how do you go from a basic idea of a question to a fully fleshed out multiple choice question that could be used on an exam. So our goals today are to kind of talk about multiple choice questions as part of an assessment strategy, to kind of talk about what makes them effective, and to look at some of the problems that can happen when you try to rate questions. So how many of you, just quick show of hands, have written a handful of multiple choice questions? Okay. How many of you put together a whole exam, like a quiz or something? Okay. Okay, yeah, it's good times. By the way, I own stock in Johnson & Johnson. We won't be talking about any maybe Band-Aids. Maybe Band-Aids will come up. I don't know. That's right. No Levaquin brand name question. I don't even know what the hell Johnson is. Other than Band-Aids, I know they make Band-Aids. Probably some surgical devices, artificial hips or something like that. All right, so, when you think about tests in general, right, we're trying to kind of do two different things here that maybe cross over each other, right? So number one is making sure that your students actually know and have mastered the material that you're trying to get, right? Whether, you're looking at skills or you're looking at medical knowledge or whatever, right? Have they mastered the stuff that I want them to master at the end of the period of instruction that we've done? And then sometimes they're used for discrimination, right? For determining grades, or where somebody stands on a rank list or that sort of a thing. And those two things, like I said, there's a fair amount of overlap between those two things. That tests motivate learning, right? Everybody teaches to the test. There's all these UWorld and question banks and score books and tips and hacks and stuff like that. And basically it's like, this thing is going to show up on the exam, so you should know it, right? And if the thing doesn't show up on the exam, students don't think that they necessarily need to know it. So sometimes, there's this sort of interplay between what shows up on a test and what's being taught. And, we're writing a test and trying to test what's being taught, but the people teaching the things are trying to teach the stuff that's being on the test. And so there's this weird kind of circle that goes back and forth. Tests can also be used formatively, right? We can help identify areas of weakness, things that a student needs to study, or even how a curriculum is doing, right? If you have a set of test questions that your students are consistently testing poorly on, maybe you're like, I should rethink that module. I should rethink how I'm teaching that information, because clearly the students are not learning what I need them to learn. So as you start designing a test, one of the first things you should think about is like, what are we going to test, right? What information is going to be on there? And so for us, for this group, right, who are clerkship directors or leading students in emergency medicine, we should really be aligned with the CDEM stuff. And as Navdeep can talk about, we are right now in the middle of a big, giant overhaul of that. How many of you guys were aware that we're overhauling the CDEM curriculum? Let's see a few heads nodding. Yeah, good. Okay. Matt Hughes is doing a great job leading that process, but Navdeep and Meredith and a bunch of other people have also been contributing to that. Sarah, are you part of that effort? Yeah, So, so we want to make sure that what we're testing aligns with the objectives of what we say we're trying to teach, right? That's an important thing to do. We should also build a test that sort of, has a good distribution of all the topics, right? So you're not testing these weird esoteric points, like the ABEM exam, for example, but you're testing like the stuff that's common and shows up on a daily basis, and the things what you think is most important when you're teaching them, that should be emphasized on the exam. The amount of time, that's sort of the same point there, but the amount of time should sort of reflect, how much importance this is. And whatever items are on the test should be representative of the content. Again, you don't want to be out in the weeds. You kind of want to be testing the main content. And I think the ABEM exam is a great example of what not to do in that regard. But that has a little bit different of a testing goal. So the other thing that you want to do when you build a test is you want to sort of make sure that it's psychometrically good, strong. And this is sort of an interesting part of working at NBME is they employ like millions of psychometricians. And they will like pound you to death with the statistics of like how this test question is doing. And you can get like a whole PhD in just like multiple choice questions if you really want to. So boiling it down, you want to have good sampling, right? So again, you want sort of your content that you're testing to sort of match the content of your objectives, the content that you're teaching. You want your test to be feasible, right? You want to actually be able to do this thing. If you're going to build a 3-hour OSCE and then you have 50 medical students to run through it in a half day to test them all, like that's not really a feasible thing to do, right? You want your test to be versatile. And I think a lot of us learned that lesson when COVID rolled through, right? We had to really, really, really shift gears. We couldn't just take this test and kind of tweak it a little bit to make it work. I know we were doing a big capstone thing with our third-year residents that was like a half day over in the Sim Center, and like we had to completely throw that out the window. We couldn't do it anymore. And then when we started thinking about statistics, right, we want a test that's reliable. So we wanted to be, if the same student took the test again and again and again, they would get basically the same score every time. And we want it to be valid, right? We want to make sure that the test is measuring the things that we want it to measure. When you put all that stuff together, and then you think about this bigger picture stuff, right? Putting together the sort of the logistics of manning a test, right? Building a blueprint, deciding what's going to be on the test, being able to make the test secure, and to actually assess, does my test do what I think that it wants to do? We sort of get to a point where multiple choice questions are an easy answer. They kind of solve most of the problems of building and designing a test and administering a test that way, right? So we love multiple choice questions. They're familiar. We see them all the time, right? You basically grow up answering multiple choice questions. They're very reliable. They're super efficient. They're easy to write. They're objective. You can make them cover whatever content you want to cover for the most part. And we can do a lot of item analysis, right, and see how is this question performing, how is this test performing, again, is it reliable, is it valid, is it covering the stuff that we want it to cover. So we love multiple choice questions for that reason. One of the big problems with multiple choice questions, and the reason we're here today, is they really depend on how well those questions are written, and also, how your students do digesting that information, right? How many of you have ever worked with a student who's on a learning plan? Right, and gets a little extra time to do a test, like probably everybody in this room, right? They take a long time to process. It's easy to write a test that just kind of favors what I call flashcard facts, right? Isolated recall stuff you can put into an Anki deck. That's super easy. And it's harder to get into some of the different levels of Bloom's taxonomy. And if you're not careful, you can actually write questions that basically give away the answer, even if you don't know what the question is about. And I was trying to find it online. I couldn't find it. But the NBME has this really fascinating worksheet. It's 10 multiple choice questions. They are literally gibberish. They ask words like that they're not even English words. And when you go through, you can answer probably 8 or 9 of the questions correctly without having any idea what the question is asking about, just by the way the test is built and the questions are written. So you really have to be careful when you're writing questions to avoid those kind of things. And we'll talk about some of those pitfalls in a few minutes. All right, this is a thing you guys have all seen a bazillion times, right? Bloom's taxonomy. And the problem with multiple choice questions is they're basically down here, and it's really easy to just sort of get at this level of the pyramid. And really, 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 we want to get to these higher levels to make sure that our students are out there and capable of doing what they need to do, right? Especially these days with Google searches. Like how important is it that you can recall some isolated piece of knowledge? It's not really that important anymore because you can Google it in 8 seconds, right? And so you have to understand, like, well, how do I apply that knowledge in this clinical situation? Like, that's more what we're looking for. So some of the things that test knowledge, matching questions, definitions, identify, things like that. As we get up into comprehension, the next level up, asking people to interpret some stuff, right? So here's some lab values, here's a test result, put that into this information, explain what's going on or predict what you think is going to happen next. And then as we get to application, the next level up higher than that, right? Putting the information that's given to you in a question, put that to use, put pieces of information together, solve problems, predict things based on the data that's given to you. And we'll look at some different examples of that. Most commonly, there's a bunch of different formats of multiple choice questions. The NBME put out this really fascinating book that's all about writing multiple choice questions, and I'll put a PDF of that later. But they have at the back of the book is this index of like discarded multiple choice question types. Like they've really done a ton of experimentation of like, oh, you can do questions this way, you can do questions that way. And they've really, really crossed off a lot of interesting ideas. And so most of the questions that you see are what are called A-type, where there's one best answer. You have 4 or 5 choices to go from that answer. They have tried some different things with these extended matching. Those are really, really, really hard to write and also really hard for students to process, so they don't use those very often. Occasionally you'll see what are called the K-type, although they really have pretty much phased those out, where you might have a choice of answers. You're given answer choices A through H, and it's pick 2 or more of the correct answers. Then again, those are hard for students to process, so they don't use those a whole lot. They have another one that's called F-sets, where you answer one question and then you get a second question that's related to that first question, but you can't go back and change your answer to the first question. So you might have a clinical scenario and it's like, what do you want to do? And you're like, give albuterol. And then it's like, the patient gets some diltiazem and now this thing happens, and you're like, ooh, that was the wrong answer, right? But so they build it so that you can't go back and change that first answer. But that way you can kind of build, you build these nice clinical scenarios and you can get a little bit more testing out of it rather than every time they have to read a whole new scenario. All right, so we're going to talk basically about sort of some general vocabulary and overview, just so we're all on the same pages of how to do this stuff, right? So the typical multiple choice question starts off with a STEM, right? That's the big chunk of text at the start of the question. It's usually a clinical vignette. And then there's what's called the lead-in. That's the last part of the STEM, and that's like the question of the question, right? So which of the following? What do you predict will happen next? What do you want to do first? And then the options are your answer choices. So up here, right, this is basically just a lead-in. A deficiency in the production of which hormone will impair the production of a concentrated urine, blah, right? So what do you think about that as a question? Yeah. Man, so this is also the fun of working for the NBME, because they pull questions sometimes from other exams, step 2 and step 3 and stuff, and they're like, do you think this would be good on the emergency medicine exam? And they'll bring a question like this every now and then, and we're all like, no, we're ripping our eyeballs out. Right, but what else is wrong with this question? So other than the fact that this is not content that we would ever, hopefully not ever cover on one of our exams. Right, but this is isolated recall, right? This is a flashcard fact. Like, you either know this or you don't. There's no way that you can put this together. There's no processing of this information. It's a thing I can Google, right? So when we look at the stuff going on with the question, when we look at the answer choices, there are also what are called distractors, right? So there's the correct answer choice and then the distractors. And I will say from personal experience, and I don't know how Meredith or Deep or anybody else who's written questions feels about this, that, in my opinion, is the hardest part of writing a question. It's easy to come up with a concept. It's easy to sort of write a clinical scenario to test that concept. It's easy to be like, here's the right answer. And then you got to come up with 4, not just incorrect answers, but 4 plausible incorrect answers that make sense in the context of that question. Right? Yikes. Those are hard to do. Okay. So when we actually start writing questions, we want to kind of have a template that looks basically like this, right? So A, patient description is unable to do this thing, right? And then, which of the following is most likely to have been injured? So this is our STEM up here. This is our lead-in. And then we have these different choices that we can do to write our question, right? So we can have a patient with symptoms, past medical history is this, vital is this, right? And so now I can build this nice kind of clinical scenario, and then I can ask these different things. And this is one tip that I like to tell people when you have to write a bunch of questions, right? And especially when you're writing questions for a big exam, where maybe you want multiple versions of that exam, but you want to test the same content, right? So I can take this same exact scenario, and I can build a bunch of different questions out of that one scenario, right? So here's a person who comes in and they are short of breath and they have a history of heart failure and COPD and they just got out of the hospital for pneumonia and they're not taking their anticoagulation for their AFib, right? And so they have a bazillion different reasons to be short of breath. And now I can say, like, how do you want to figure out why they're short of breath? Or here's a piece of data, a chest x-ray, an EKG, a something, right? What do you want to do with that data in the context of this STEM? Or here's a piece of data, what's their diagnosis, right? And so you can imagine, like, I can use that same STEM to write a whole bunch of different questions. Okay, so when you put stuff in the clinical vignette, the NBME likes to use a very specific order. This is a good thing because it makes students sort of very familiar with things. So as we go through questions later this afternoon, we're going to try and make sure that we're all following the same template. So again, when a student, when they get to the lead in and they're like, wait, what was the patient's vital signs, or they kind of know where to look, right? It's just like when somebody gives you a presentation. If they start off with their assessment and then they give you a physical exam and then they start adding in some history stuff, you're just like, hold on a second. Like, this is not how this is supposed to be. And it's the same thing with students in taking multiple choice tests. So we want to make sure that we're kind of consistently writing things. So basically you start off with why are they here? You give a little bit of history, including any relevant past medical history and medications. And then your physical exam stuff. And I like to use those last two things to kind of help build out sort of plausible things on the differential that I can then turn into distractors, right? So like I said in that first one, if I have a patient who's coming in short of breath and they have a history of COPD and CHF, great. Now I can tweak the question so the right answer is COPD, but CHF is a plausible distractor, or the other way around. All right, it's important that your questions focus on one concept. I don't think I've seen a lot of questions where people are trying to test three concepts simultaneously, but that is kind of like a research study, right? Like when you're doing research and like, I'm going to do this survey and I can ask about this and this and this and this and this, and then your survey results are a mess. So one concept, right? Try to pick on either pretty common stuff or kind of those life-threatening things that show up in the differential, right? Again, this is not the ABEM qualifying exam where we want to make sure that people are all the way out as far in the weeds as they possibly can get. We're testing medical students, many of whom will not end up in emergency medicine. So we want to make sure that they just know kind of the core and critical stuff. All right, we want to assess application of knowledge, ideally not isolated fact recall, and that's putting the knowledge into context. So, I guess I've already talked about that a little bit, sorry. I wrote these slides a really long time ago, and I don't remember what I was trying to say in each one. All right. The lead-in, that should actually say the lead-in should pose a clear question. And ideally, the distractors are homogeneous, right? So they're all on a same dimension. And I think I have, no, I don't. Later on, I'll look at an example of that. But it's not unusual to write a question where you're like, oh, this patient comes in and they're unstable. What do you want to do next? And then your options are like a diagnostic item, a therapeutic item, a test item, like a CAT scan, some labs, give this medicine, discharge them home, right? And so you're kind of like trying to decide between a disposition, a treatment, a diagnostic step. And that can be really, really hard to process, right? As we all know in emergency medicine, you're often doing all of those things simultaneously. So if you give them one axis, right? I want to treat with A, I want to treat with B, I want to treat with C, then they can decide A is the best treatment, C is the best treatment, whatever. And they're not trying to sort of work in a three-dimensional space to answer the questions. Ideally, also, they should kind of be about the same length. And we'll talk about this. This is one of the common sort of mistakes that people make is the right answer is like 3 paragraphs long and the other answers are like 1 word, and it becomes easy to pick the right answer just because you're like, oh, it's got the most information in it. All right, we want to avoid negatively phrased items like the old except, least, not. We don't write questions like that anymore because that basically turns into a series of true, false questions with each of the answers. And then we'll talk about some of the test wiseness stuff. But again, there's lots of little things that we accidentally do when we're writing exam questions that really, really cue what the correct answer is. So just for example, like repeating a word, you have a word in the stem and a word in the answer, and like that's the correct answer. That becomes really easy to answer if you notice that. Or sometimes also just making questions ridiculously hard. And another one that I forgot to put up here, but it occurred to me as I was looking over the questions that people submitted, is the sort of, you have a very clear idea of what you're asking about when you write the question, but the person who didn't write that question has no idea what's going on. So you're like, oh, I'm going to write a question about aortic dissection, and you write this great chest pain case, and you're like, of course the answer is aortic dissection, because I knew that when I wrote the question, but looking at the facts that got put into the question, that's not always clear. You want to keep your patient presentations pretty simple. Our patients don't lie. That's a big one. I used to put that in all the time. I'm still tempted to do that because that happens to us in real life, right? They leave out information. They tell us weird stories. They don't bother to mention how much they're drinking or which drugs they use or whatever. But that doesn't happen in the testing environment. We try not to use the patient's real words unless it's somehow relevant to the case, so patients come in for dyspnea, not because they couldn't breathe, stuff like that. And then if you're going to use labs, there should be some reference information. And so the NBME has a list of like really common tests, your CBC, your CMP, that kind of stuff that's you get when you take an exam. If you're going to get kind of outside that realm, if you're asking about TSHs or some test that's not super commonly ordered, just give them what is the normal for that test, right? Because we're not testing the student's recall of do you recognize red or blue when the labs pull up an epic. We're testing, how do you put that information into context? All right, as you build your STEM again, you want to focus on an important concept, right? So think of a thing in CDEM curriculum, right? I want to test chest pain. I want to test aortic dissection. I want to test, a small bowel obstruction. Watch out for the negatively phrased stems where you're, again, not asking about what the patient doesn't have. Try to leave out any irrelevant information and avoid all of these different technical flaws. We're going to try and work on getting into that application level of knowledge, right? So giving patient findings and then synthesizing that. We can do some pathophys and say, well, why is this happening? What's the mechanism by which this happens? We could ask them to solve an if-then problem, right? If this thing happened, then what would you want to do next? We can ask them to interpret data, or we can ask them to select a course of action. These are kind of the big, broad categories of what we can do in emergency medicine. We don't do a lot of the pathophys stuff. We could probably do more of that. And again, like I said earlier, once you've written this really great STEM, a lot of times you can take that STEM and build multiple questions by using permutations of these different things that we can ask about. Okay. These are some of the topics that we can get into. We don't do a lot of health and health maintenance stuff, but I always think, these are NBME categories, by the way, sorry. I always think of this one, that health is like sort of why the patient came to the ER. I had these symptoms, I'm in this risk category, right? I'm an older white male with diabetes and hypertension coming in with chest pain. That to me is a health and health maintenance type category. We can ask about mechanisms of disease, diagnosing different things, or managing different problems. And again, resist the urge to sort of cover multiple of those topics in one question. Those should each be separate questions. So some of the lead-ins that we might write after we wrote a STEM, right? What's abnormal? Which is the most likely finding? If you think a patient has disease process X, what physical exam finding is most likely? What's the most likely cause? What drug should we give? What's going to be your first step in things? I don't use most effective management a lot. I think that gets a little bit too subjective, but that's one of the ones that the NBME suggests. Right? If we have infectious kind of stuff or systemic inflammatory diseases, you can ask about pathogens. You might ask about antibiotics in a similar vein for that. So when it comes time to construct distractors, this, like I said, is probably the hardest part of all of this, is coming up with distractors that are wrong but plausible, right? You could have this problem. You could use this medication, but it's wrong for whatever reason. And this is where paying attention to what your students do when they're presenting patients to you can really, really pay off. And that's been one of my biggest source of test questions, is when a student makes a presentation and makes a little error like that, and that's going to be a good test question, because they've already done it for me. Be sure that whatever things that you're giving are not overlapping, right? So if you're going to ask about antibiotics, giving them a second and a third generation cephalosporin, that's probably a tough distinction for a student to make. Or giving 200 cc's of fluid versus a liter of fluid or something like that, right? The right answer is give fluids, not give this much. One of the things that you can do is use stuff that sounds good as incorrect. I know the ABEM test writers like to do that a lot, just throw out random words that you're like, I'm not really even sure what that is, but it sounds really good. Or true statements, right? Things that are factually correct, but don't answer the question or are not the right answer for that particular correction. This one's hard for me, avoiding the use of humor. And then when we put the test together, we always put things, the NBME does this too, you just put all the answers in alphabetical order. So you don't have to worry about I have too many C's on my exam or too many B's on my exam or whatever. In terms of the answer choices, we're just going to put them alphabetically. And sometimes we'll change the wording of an answer so that we can put it alphabetically, one place or another. Or if you're giving numerals, right, if it's, 100, 500, 1,000 or whatever, well, again, we'll write them sort of in order of the numerical values. All right, one of the things that we do when we go through tests is we look at the answer choice frequency. So when students, when you get a test back, it's like 3% of students chose answer A and 7% of students chose answer B and 58% of students chose answer C, and that was the correct answer. So you want to make sure when you're doing that level of analysis, and we'll talk about that a little bit more in a second, that at least some people pick that answer, right? If you have 0% of students picking that answer, that's not a great distractor. Maybe you should consider rewriting that question or rewriting that distractor. One of the other analyses that you can do is what's called a high-low analysis. And again, we'll talk about this a little bit more. But basically, you look at the performance of the test or any question in the context of the test with the students who were in the top quarter of examinees, the ones who did the best, and students in the bottom quarter, the ones who did the worst. And you kind of want to see, how did those students answer this question? Did I have a lot of students who otherwise did well choose the wrong answer? That's not a good thing. Right? Ideally, you want a lot of students who didn't do well chose the wrong answer, and none of the students who did well chose that wrong answer. Okay, so that's kind of ideally what a distractor should look like, and again, we'll look at an example of that in a second. So we talked about this a little bit before, right? That we want ideally our answer choices to be homogeneous here along one axis, right? So this is a treatment, this is a treatment, this is a treatment, this is a treatment, and this is the best treatment. You could do this, but this is better, right? And you probably wouldn't do those things. Maybe this one is even completely wrong, like it's contraindicated type of a thing. But we have this nice spectrum, and so there's enough space between those things to easily say, this is the right answer. If I gave this question to a group of experts, everyone agreed, this is the right answer. And this is one of the harder parts. And it's kind of fun when we're working at the MBME doing these questions, because we'll be sitting in a room and somebody will be like, well, this is what we do at our hospital, and the rest of the room will be like, really? That's not what we do at our hospital. So you have to be a little bit careful about this. If you have kind of institutionally specific things, those may not necessarily make great questions. But one thing to keep in mind here, right, those incorrect options might not be totally wrong, right? They might just not be the best choice. This is the best choice. And that also gets tricky too, especially when we're talking about what's called sequencing questions, right? Which action would you do first? If you're resuscitating a patient, you're probably going to do all of these things, right? You're going to get access and take a chest x-ray and give some fluids and, all of these different things. But what's the thing you would do first? Well, typically, right, that's A for airway. And if airway is okay, then it's B for breathing, right? And so if you write questions that way, again, these are things you would do, but you might do one thing before you do the other. All right, in general, once you've written a question, it should kind of look like this. You should have this nice block of text that's your stem. Your lead-in would be the last part of your stem, and then you would have these answers, the option choices, right, the distractor and the correct option, that are all about the same length. All right, so some of the common problems that we see, one of them is just grammatical stuff, right? So the next step in management includes administration of, well, I don't administer most of these things, but I do administer that, so what's the right answer? Right? So be careful about little stuff like that. So we might rewrite this question to do this way, right? Which of the following is the next step in diagnosis? Because now I have a choice of diagnostic tests, right? And it doesn't matter which of these things I'm doing. Those are all diagnostic tests. They're all on one nice axis, right? And here you can see, right, this is clearly the right answer in this context. The next most appropriate step. I probably would do this. I might do this. I don't know if I would do those. I don't usually do those, but maybe, right? Students see those things done. So none of those things are wrong, but this is very clearly the right answer, right? So now you can kind of picture that continuum that I was talking about before, where this is way over on the one side, these things are kind of over on the other side. Maybe this one's somewhere in the middle. All right. Be careful when you're writing your answers that you don't sort of cover all of the bases with the set of answers, because then you can very easily rule out several of the answers and make it easy to guess, right? Because your plasma volume cannot increase and decrease and remain the same, right? So I know of those three, only one of those is correct. And because they gave me everything, right, these two don't even matter anymore. And so now I can just kind of hone in on this, does it go up or does it go down? All right, this one you guys always know, right? Be aware, always, never. Those are never the correct answers. We don't ever rate those. Those are mostly never the correct answers. Be careful with this one. This, again, super common error, right? Where you get the short thing, short thing, short thing, big, long one. Students will pick up on that right away. How many of you guys do those, like, say that again? Yeah, that's exactly right. I was trying to think of a word for it. They were always like that, right? Like, you just click, just take me straight to the test. I don't even need to read the stupid thing because this is right. You know, it's like, or it's always all the above is the other super common answer on this.
Don't change it.
Yeah. I actually took a bunch of screenshots. I moonlight at our VA, and theirs are worse. They're worse even than the regular hospital ones. And I took a bunch of screenshots, and I need to pull those out someday. Specifically for doing this talk, and I forgot to put them in there, but yeah, I was like, this is my retirement plan, is I'm going to go and rewrite all of the VA's tests because they're horrible. Right, the word repeats, so this one I talked about a little bit before. You know, so this guy with heavy alcohol use is saying that, you know, he's confused, he's agitated, the world is unreal. That seems awfully suspicious, right? So stuff like this where, you know, none of these other answers really kind of make sense, but, you know, if the world doesn't feel unreal, derealization sounds like the right answer to me. Correct answer includes the most elements in common with the other answers, right? So this one's super common where you're trying to pick two answers, and I can see, well, was it vancomycin shows up an awful lot there. Zithromax only shows up twice, so it's probably vanc. I'm just going to guess one of those answers. And so again, you can kind of rule out some of the other answers just by the frequency of stuff. And one way to get around this is, like, if you want to test, you know, why do I give 2 antibiotics? You might say, like, in addition to vancomycin, what other antibiotic do you want to give, or phrase a question that way. Or another thing to do is to just write out all of the answer choices, right? So maybe you give 3 antibiotics and it's like combination A and B, combination B and C, combination A and C, combination, you know, and just kind of work your way through that way so that there's an even, you know, all the different answer choices are represented with the same frequency. You know, don't make this harder than it needs to be, right? These questions for students are a lot harder than we think that they are. I am frequently surprised when we go back through exams. I'm like, man, I thought that question was super easy, and only 20% of students got it right. So things are hard enough, so don't make it any harder, right? So when you write your options, make them as simple as possible. When you put in numeric data, make it very straightforward, right? Don't use vague frequency terms like this rarely happens, this often happens, but try and define it if you can. Your options should follow a nice logical order, right? So if you're asking about a number, the numbers go from smaller to bigger or bigger to smaller. We certainly do not use none of the above or all of the above. And, you know, again, be careful with your stems. Try to make them as straightforward as possible. And sometimes you, unfortunately, have to add in what feels like excess detail, again, to make some of those distractors more plausible. So be a little bit, you know, be careful about how much information is going into stuff. All right, so this is an example of like a painfully complicated test question, right? We wanted all of the answers with equal frequency, so we've got all the different options here, but like, man, there's Roman numerals and Latin numerals, and then there's like chromosome stuff, which can also be interpreted as Roman numerals, and I, you know, like, oh my God, like just looking at this question gives me a headache without even reading it, right? Plus, that's so relevant for emergency medicine. So don't write answers like that. Okay. Here's another straight up knowledge question, right? So what's a thing that we could maybe do to make this into a better question? Right, this is pure recall. Yeah, give some clinical symptoms, right? So maybe we turn it into something like this, where this guy comes in with, you know, some weakness here, difficulty speaking, right? We got a physical exam, and so we can start to localize that lesion. And now we're basically asking the student for the same information, right? But they have to kind of put it together in a clinical scenario as opposed to just knowing this artery goes to those parts of the brain. All right. Oh, right. So this is the same question again, sorry. But now instead of asking, right, where's the lesion, we're asking, what would you want to do here? right? So this guy's having like a stroke or a TIA. Would you want to give him TPA? Would you want to start him on antiplatelet therapy? But we can, so we can basically use that same exact STEM to ask a different type of question. All right, now we're going to kind of change gears and just talk a little bit about test analysis. And this is, if you're just writing questions, this is maybe not so important. But this is one of the things, we used to do this with the SAEM exam, and they changed testing software on us, and we are currently not able to do it at the level we want to, and we're working on that. But when you start getting questions back, right? So when students have taken an exam, ideally you run these reports on your exam and you actually look at the exam as a whole and each question relative to how that student did on the exam. Okay? And we can get a whole lot of information out of that, just those two pretty basic analyses. So discrimination is essentially how effective the item was. How did it do separating the people who really knew what was going on from the people who maybe didn't quite know what's going on. And difficulty is just the straight up percentage, how many people got the question right. Okay, and we can talk about difficulty as a whole, but you can also talk about difficulty with subpopulations of test takers, which again sometimes helps you do some diagnostics on your test. And then there's a bigger statistic that you can run on the test as a whole for internal reliability. And ideally at the med student level, the medical school level, I should say, for these big high stakes tests, that number, you probably want it higher than about 0.7. And that's a thing that will come back again. When you use good testing software, they will just give you that information. And that score is kind of based on how many questions there were, the overall difficulty of the questions, and the total length of the test. All right, so the difficulty index, this is pretty straightforward. Who got it right, right? And if more than 90% of your test takers are getting the question right, it's probably too easy. If less than 20% of test takers are getting it right, it's probably too hard. Ideally, you want this somewhere in the 0.5 range, but we will accept anywhere from about 0.3 to about 0.9. Once you get over 0.9, we start asking, like, is it really even worth having this question on the test because everybody's getting it right? The more answers you have on the test, it actually affects the difficulty a little bit, right? So when we look at ideal difficulty, we ideally want to write questions that have at least 4 responses and ideally 5. And occasionally it's so hard to write 5 good responses, with like good distractors and stuff. Like if you have 4 responses and a distractor that nobody's picking, what's really the point of having that fit distractor in the first place? But if you can't write a question that has at least 4 responses, that's maybe a question that we need to rewrite or rethink because it starts to affect the overall difficulty of the question, right? It becomes easier and easier to guess if questions don't have enough answers to pick from. All right, the discrimination index basically is how did this test do or how did this question do, again, in determining the students who knew what was going on from the students who didn't. And the way that we calculate this is we look at overall test performance. So I take the top quartile of students, the 25% who did the very best on the exam, and I compare it to the 25% of students who did the worst on the exam. And what I'm basically looking for is, like I talked about earlier, where I want to see that the students who did well on the whole subject test also did well on this question, and the students who did poorly on the whole subject test did poorly on this particular question, right? That means that this question is doing its job, is kind of falling in line with all the other questions on the exam, okay? And this is an example of what that looks like when you print it out on my test taking software. So these are my different answers and who chose stuff, and I can see that among my high performers, right, 52% of it chose the right answer, and among my low performers, 68% of it chose the right answer, right? So that's not a very good performing question. We don't like that question because low performers chose the answer better than high performers. Basically there's an interplay between the difficulty and the discrimination value. So harder questions tend to discriminate better. And if they're not, you should probably rethink that. Right? So if you have a really hard question, nobody's getting this question right, and it has a low discrimination value, that's just like it's a hurdle to your test takers, right? It's not helping you sort out your students. It's just a really hard question, right? And so if you want sort of a moderate difficulty question that really does a great job discriminating your students is the best thing, right? Because then students can get through lots and lots of those questions, and you're really sorting them into groups. We always want to think about how does the question do discriminating if it's a hard question. If it's an easier question, that becomes a little bit less important, right? Because that's, easier questions students are getting through anyway. But this is important, again, as we're thinking about sort of the whole exam, and a question that performs poorly, right? If it's a hard question that doesn't tell you the difference between students, just throw that one out. Get rid of it, write a new question. I feel like we've already talked about most of this, but so this is sort of the flow of how we build a test. So we write questions, right? That's what we're going to do in the next little bit of here. We put them into an examination, excuse me, and then we run through a bunch of tests. And the NBME actually has a life cycle for their questions. So they do some pre-testing for 2 years before they put them into the exam, and then they'll keep them in there for as long as 7 years, collecting statistics. And then eventually they will cycle them off just for exam security. And I was talking with somebody just before we started this exam, that's one of the problems with the current SAEM exam is we haven't cycled stuff off of there in a long time. So some of our questions are getting kind of dated. And I'm sure that there are security issues with the questions that are on there. And again, that's part of why we're running this workshop, is because we want to get a bunch of new questions for our exam. Ideally, you have a big bank, right? So you have 28 questions on hyperkalemia, so that if one of them is not performing well or gets compromised or it seems out of date or whatever, we can just pull another one, right? And then you can maintain your test blueprint. We can have our overall content stay consistent. And ideally, that's a question that's been pre-tested and you know the statistics. So now you're not only having the same content, but the same difficulty, the same discrimination, right? All those same pieces parts. So you're just kind of plugging questions in and out of your exam. All right. What questions do you guys have?
I just have one. That 10 questions that they gave you. It was just a measure of quality on the question.
It was, sorry, say that again?
It was giving to all the people like the same.
Yeah, it's a worksheet, and it's like all of the Flargle blasters,
How go you test wise in the question?
Yes.
What basically came down to the higher your score was, the more test wise you were at SAEM. Or as a test taker. And the lower you were, you got green scores on the test, it was all based on the numbers. That's all how you fall from the entire test like this. So you did bad at the central language, you got that take and Jewish. Everything you did on the actual exam, it wasn't based on your test one, it was based on your actual ability. That's what I did.
Yeah, I mean, I think the point that they put, I don't disagree with what you're saying. I think why they put that together was just to show, like, if you make some of those test wiseness errors, students can answer your questions whether or not they know what you're talking about. Right? But that's like you said, if you're test wise, you will do well on tests, right? And we know this, right? People who do well on tests are people who do well on tests. I'm sure you've all worked with people who were great clinicians and failed their in-training exam or whatever. All right, stand up, stretch. There's some coffee and snacks in the back of the room. And then, I don't even know what time it is here. Oh, we did pretty good. I put a QR code here. And so if you brought your computer, that should take you to a Google document. This shared SAEM practice exams document. Most of the people who pre-registered for this exam, I think you should already have this link. And if you would, just put your name and email on here so we can get in touch with you afterwards. What's that? Yeah, join the CDEM assessment group, definitely.
Yeah, no, I agree with what Tom said. For assessment, we're probably the SAEM test for the pre-test, the practice test, version 1 and 2. We'll need a lot of help to pay the curriculum. So if you want to help out, one of us, we're happy to you guys help. That's really fun to write questions.
It is lots of fun. And if you're interested in doing stuff for the NBME, they actually have, if you go to nbme.org, they have a sign up, like if you want to volunteer to get on committees and write questions for step 2 or step 3 or the EMAs or, clinical skills exam, any of that stuff. They are always looking for people. They're based right here in Philadelphia. They pay for you to come to Philadelphia. It's wonderful. They put you up in a great hotel and you hang out. Why are you shaking your head? It is helpful. But no, it is. It's a lot of fun. And, you know, you get to sit around with other emergency medicine nerds talking about test taking stuff. All right, so I kind of cherry picked. I asked more experienced test writers to write some questions, and then I cherry picked a few just so we could talk a little bit about kind of the overall process of like, how does this work? How do you write questions? How do you workshop questions? I'm going to blow this up just a little bit to make it easier for people to see. Oops. All right, everybody, can you see that okay in the back of the room? Should I make it even bigger?
Maybe a little bit bigger. Okay. I actually wear glasses right now.
Just for you, Deep, I'll make it bigger. All right, so this first one I picked because it sort of mirrors my own process when I'm starting to write exam questions, right? I just come up with this idea of like, oh, okay, sudden onset VFib, right? And students should know to start CPR right away, not do anything else. And I think like that's a great testing point, right? Does anybody disagree that that's the thing students should know? Okay, right? It's a thing in CDEM curriculum. We love it. All right, you know, then I have sort of this note to self, right? I need to find a picture of VFib, and that's one of the difficulties of making national standardized exams. We can't use stuff that's already on the internet. We obviously can't use copyrighted stuff, so I'm gonna have to dig through my files, or the person who submitted this question is gonna have to dig through their files and find a picture of VFib, right? I probably have an EKG with VFib on it somewhere. Ideally, it would be a monitor picture because the question says I see this on the monitor, right? So if I give them a 12 lead, like that might seem a little disingenuous, right? But what are some problems with this question sort of based on all the things that we talked about? Doug.
So like there's the answer is very short, but it becomes a much longer response.
Okay, so the length of things, I kind of agree, right? The length of things stands out. Start CPR as the correct answer, just visually looks different from all the rest, so we maybe should lengthen that. So maybe we could do something like immediately initiate chest compressions, right? Or something like that. You like that better? Right? Like now kind of fits in with all the rest of the answers. Okay, I like that. There's not a lot in that step. Right? This almost seems like an isolated recall that we're asking a person to translate the picture of VFib into, oh, that's VFib. What do I do with VFib? So there's a couple steps there. So I guess I'm okay with that. But now how about this? What do you guys think of those distractors, right? If you recognize that this is VFib, I got one good distractor, defibrillate, but like, how many students would be like, ooh, VFib, lorazepam? Right? I don't know how plausible that is. Or how about intubate? I don't really have any other information. And even as I think about that, like, is this patient pulseless? That might be right, because if the patient had a pulse, like, maybe none of those are the right answer. So I feel like we need to add a little bit more information. But fleshing this stem out, you know, now we can make it right. So just as I'm thinking, lorazepam, I like that as a distractor. Sometimes people twitch a little bit, right, when they go into VFib. So maybe the patient has like some unsynchronized myoclonic jerks or something like that I could put into the stem to make the lorazepam a more plausible distractor. What do you guys think of that? See some head shaking? Okay. Throw something else out there. Like how else?
Like thinking of like, hey, fortunately, I get some benzos so they don't remember the pain. Maybe that's what they're thinking. I don't know.
Okay. Okay.
Something along that thing.
or maybe a different distractor than the lorazepam. Then I don't know. That was my thought. Was like, people get twitchy sometimes. Okay. Oh, epinephrine. I like that. Let's actually make that a fifth one. Okay. So let's add some stuff here, right? So we need like kind of our usual things. So this is our scenario. Patient becomes unresponsive during your exam. Do we want to add some information? Maybe it's like a 60-year-old man being evaluated for chest pain. And then we'll say the patient becomes unresponsive during the exam. And maybe he is pulseless. Right? And now suddenly endotracheal tube seems a lot more plausible. He's not breathing, right? And that's not a wrong answer, but it's certainly not the first thing that you would want to do. Okay.
So what is utility if you got things like 120 beats per minute or 100 to 200 joules? Does that level of specificity help or hurt?
No, it doesn't.
Just put initiate chest compressions versus defibrillate versus, I administer epinephrine IV.
Yeah, it doesn't necessarily help. I mean, you might, right, if you wanted to test their knowledge, you might say initiate chest compressions at 30 beats per minute, right? Or versus 100, versus 120, versus 200. Like, you might be testing that point. You could just leave this at initiate chest compressions. I think that would be fine. But since there's numbers and a lot of other answers, sometimes it makes it consistent to let me add a number here just for consistency's sake. Right? Because it's not so much the 120 that makes it correct, it's chest compressions that makes it correct. Or you might say initiate chest compressions for 2 minutes, right? Or something like that. What else can we do to tweak this question? We got this lorazepam. So we either need to change that or add something that makes it a little bit more plausible. And I think the rest of the answers seem a lot more plausible already.
You want to change E and do it.
Sorry, oxygen? Okay.
I mean, because everything takes work. I'm able to monitor.
So instead of lorazepam? Okay.
Goes along with everything.
I can't type. Something like that? You guessed that would work. Okay. I don't know. Right, this is a group process. So, $110%. That's even better. Yeah. Yeah, I mean, that was sort of my thought with like the twitchiness of, when people sometimes pass out like this. I think you could go either way with that. I think motion artifact becomes tough when you say he's pulseless. Yeah, you could. Well, sure, you could certainly add a history of seizures. I think that would be fine. You could.
Shaking, right? Like he becomes unresponsive, and you witness shaking. Would you?
Yeah, there are several myoclonic jerks, non-symmetrical myoclonic jerks are noted, or something like that. You could add. I was just thinking you could maybe. What if we took out the pulseless part, and instead of initiating chest compressions, the right answer was check for a pulse. right? Because then, something like motion artifact becomes a more plausible. But you can see, right, this it gets a lot harder when you get into like the nitty-gritty of like how do you actually do this and turn this into a question. Like I said, it's a great idea, it's a great start to a question. Now we got to make it into like a workable question, and I think we're 95% of the way there.
Doug, I like your suggestion because some might choose to defer early or just convert. If you have that ability, if I can immediately defer early, as opposed to 3 minutes later. Right?
Yeah.
So if you change it to check for a false, then that eliminates early as well.
So you would change A to check for a pulse, and then we'll get rid of this. What do people think of that?
That would also force you to differentiate if you think, you're trying to put something about seizure in there.
So this, what did I just do? I think, that I think becomes an easier question, but that's okay. Somebody's got an EKG strip. Awesome. So we would, instead of this one, I don't like this keyboard. And then did we want to add something about seizure?
You could put something like 60-year-old male, history of chronic alcohol abuse.
Ooh.
Or seizure without things.
I feel like check for a pulse though is what you would do before any of these things. So I feel like it kind of becomes check for a pulse. Is that not?
I don't disagree, but I think some students, when they see the VFib on the monitor, like VFib defibrillate, right? And so, but this is one where you would want to be a little careful, right? And kind of when you get those test statistics back, be like, wait, are the smart ones choosing defibrillate, right? And the ones that are going into ortho are like check for a pulse, because you want that to ideally be the other way around. So sometimes when we're writing these questions, we'll do that at NBME. We're like, we'll leave it as it is and we'll see how it tests. And then 3 years later, we're like, wait, what did we say we were going to do with this? Because that's the hard part, is trying to remember that.
Would be more confusing or tricky if you say more actual multitude.
Would you put multiple choices? Okay.
Just make it more clear as to which. I don't know if that's
Okay. I mean, I don't know that I, as an instructor, would care. I want them to check a pulse, but so you're saying check for a radial pulse versus check for a carotid pulse.
right.
Okay.
Compared to all the other options, I think it's just so much easier that you're check.
Yeah. Well, and as Doug pointed out earlier, right now that one kind of stands out because it's shorter than all the rest.
Do the people at SAEM believe in alphabetizing answer choices? And the second part of the question is, will this be a time that we put in check for pulse, and rephrase it so it's lower down on the list, so it's not the first answer choice?
Yeah, you might, palpate a carotid pulse or something like that. Like we could certainly goof around with the wording a little bit because I feel like the rest of these all sound very formal, right? Initiate, defibrillate, initiate, administer versus check. So that it does kind of stand out that way as well. So maybe we should use a more formal word there. Because check for also, I just feel like that just kind of cues, right? So. I'm sorry, I didn't hear that. I'm getting a lot of noise from the. Oh, sorry.
No, I was just saying, I think it makes it more formalized if you
Okay, yeah, so back to his suggestion, so. Take out immediately?
Because they're all action words except for immediately.
Good point, good point. Okay. See, now you guys are getting the hang of this.
Well, the thing with that, I kind of wonder, are we changing the point of the question?
Oh.
Because we initially were trying to test, what do you do for being fib? Now what do you do for responsibility?
That's a really good point, right? And so that's another thing to think about is what was our testing thing? And I agree. My initial take on this was like, do you recognize VFib and start chest compressions? Like that's a great testing point. But I also think like somehow we either need to say the patient is pulseless, right? Or we need to have them ask about this. So
Well, then kind of as an aside, what do you think about multiple questions for SAEM?
yeah, I have no problem with that. Obviously, you don't put them on the same exam. So one of the things that MBME does, they actually have like all these file codes, like sort of headers at the start. You know, what is this question about? Blah blah blah. And one of them is called enemies. And so that's like if this question is an enemy to some other question, right? So if we have two versions of the same question, then you would not want those on the same form of the exam, right? So there's two different SAEM tests now, two. Right, so we would put like one question, one version on one of those tests and the other version on the other test, just so that you didn't have the same question show up twice.
So you would have, say, for example, this question, and below that, the next step being a patient above.
Oh, you can do that. Yeah, that's what's called that F set. So there, like you probably would have very different choices, right? So like if we were gonna do that, the patient becomes unresponsive, maybe we stop there, and then your answer choices are like check for a pulse, check for breathing, check a blood sugar, right? And you know maybe give the lorazepam is in that one, and then the patient is noted to be pulseless. Now what do you want to do? And you can certainly do it that way.
Is that great? Difficult to associate like the SAEM test? It's not clear, like software blinded. They're randomized questions.
I don't know if the SAEM test has the ability to do FSET, so that has to be built into your testing software that they cannot go back and change the answer to that first one when you make a question now.
It's not currently, but we're hoping to transition to a new software platform soon.
Okay. Well, so let's make a note of that. I really dislike this computer.
This question, I almost already, if you're trying to test regarding the diseases, then take out A and B.
You would take out the what?
I would take out A and B as an option. If you're just trying to test the recognition of defib, then the thing that distinguishes the answers is the memorization. As opposed to like EA.
All right, so because that's a good point that Sarah just made, that we need to focus on, so what is our testing point, right? What are we trying to get at is the first question they answer. And so I think this at least started with recognition of VFib, right? And I think that's so let's build this question so that we're recognizing VFib, and we can come back to that other question we'll write that as a separate question later. So in fact, let's just do this. We're just going to make the two questions right now. Oh, there's a function key there that's not supposed to be there. I don't know what's going on in that other room, but those guys are loud. Okay, so the first one, let's make recognizing pulselessness, right? So becomes unresponsive, not breathing, myoclonic notions are noted. So maybe here, we'll keep the lorazepam. I really hate this. I'm gonna go move to my computer because this is driving me crazy.
You don't even need the picture to be in it.
Right. Exactly. Good point. So let's take this one out. What's another good distractor for just sort of the unresponsive patient, right? What was that? Narcan. Ooh. But I think if we're gonna have nasal airway, that's probably right. Like nasal airway versus endotracheal tube. I don't think we're gonna. All right, what do we think about that question now? Everybody like that? See, heads nodding. No one's arguing. Good.
Do you need to include reading of that point? Do you just say some myoclonic jerks? Part of that is trying to differentiate.
That's a good question. I think you could go either way with that. I think nasal airway, I don't think anyone would pick that if you don't say something about his respiratory status, but maybe you hear like gurgling aspirations or something like that, or gurgling breath sounds, or
Yeah, if you just say he's not reading, then I'm like, well, lorazepam makes no sense.
even with the myoclonic jerks. Oh, you're right. That is kind of. All right, we'll throw out an option for the lorazepam.
Or you, instead of not reading, you can say, becomes an action or something. That would in between.
Lorazepam was pretty tempting when you're trying to take this test quickly and you just look and see all withdrawals by one pairs. Lorazepam. I feel like that's
I'm sort of in your camp. I think that's a relative, like, it's not a great distractor, but I think you'll get one or two people that pick that of like for exactly that reason, right?
So at least he's not reading first and they're moving too quickly and just assume that we're going for a withdrawal feature. I think it is all and on your best to do it questions and reporting. So the worst you when I was reading is oh I see jerks. Bullshit, but it's the best I need to pick that. And then the best is the reporting. So then you come to the question and the information to be good ones are answering properly is bad ones.
Exactly. That's the whole goal. I mean, I kind of agree with Tom. I think there's going to be a handful of people that just sort of, do the superficial scan, right? Oh, alcohol, myoclonic jerks, it's a seizure. Lorazepam, next question. And the people that, really read into it and kind of put all the pieces together will say, hold on a second. Like, this guy's here for chest pain. He's an older person. Maybe we could give him something else, right? And then maybe we give some vital signs and he's a little hypertensive or something like that. So now alcohol withdrawal becomes plausible, but also sudden cardiac death becomes plausible.
So let me ask you, when you put these in alphabetical order, lorazepam is your first answer, and you kind of got to the point where the myoclonic emotions are noted. That's going to tend people to pick that answer potentially the first answer in the state.
Potentially, yeah.
So I think the order in which they go in is also just because you might have that response. Oh, that's the right answer. Boom. And you're done. You don't need to look at the other ones. Well, I'm just saying that is easily plausible, right? And so you may want to, And we'll figure out a way to change the order.
Yeah, I'll admit we don't often get into kind of the gamesmanship of like, ooh, which one should be first. Every now and then, like if you have a pretty easy question, you want to make sure that the obvious answer is a little lower down. But here, right? You would get administer lorazepam, administer Arcan, check a glucose, insert nasal airway, palpate pulse, and so palpate pulse is going to be your final answer if you.
So I'm just kind of wondering, is it worth playing around the order of the answers to change the strategy to what the answer is?
You could add a route of administration for those two meds, and maybe that intranasal margin, intravenous lorazepam.
That's
the ultimate game.
yeah. So that would change it.
Although, as somebody said before, right, you've got sort of verbs as a theme. So we would want to keep that administer either way, because then all the answers have a verb. But
Looking at every day, so make sure in this you have to do this. You want to right?
yeah, like I said, I don't know that I would sweat the gamesmanship of the answer choices too much. That's
Well, that's really what I was asking.
yeah. It doesn't really seem to make a difference, and like I said, that's why the MBME has moved to just alphabetizing, so that they don't even worry about it anymore. So
But to your point earlier, the idea that we have two options that are both medications, logically was to say, oh, we'll make, because of the two options, medications, and probably one of the two.
So it's actually, they've done a lot of research on this, and for some reason it's okay if you cue a wrong answer, right? Like you don't want to cue the correct answer by having like multiple things that sort of point towards like, okay, there's 3 medicines, so it's got to be a medicine. But that's okay if it's doing that for a wrong answer.
Maybe stronger distractors.
Maybe. I honestly don't know that one. Right, and you could tweak things even more that way by like just administering glucose instead of checking a finger stick glucose, right? Just give them some glucose. But I know, right, like, somebody said, right, glucose, the coma cocktail, Narcan, glucose, oxygen, all of those things. I think we're still teaching that, so hopefully that's a thing that would also draw students that direction of like, oh, unresponsive patient, I should check a glucose. I should think about giving Narcan. I should maybe make sure their airway's okay. As opposed to putting it in the context of like, this guy with chest pain just collapsed. I should check a pulse. All right, I think this one's pretty good. I don't want to beat this horse to death. So let's move down to the second one, right? And now we have the patient, right? Same story, but this guy is in VFib. And we should probably say that he's pulseless this time, right? So there's no question about that. And then, like Sarah was suggesting, we can maybe have some initial ACLS type interventions. Okay, so now we have this guy with VFib. We're going to take out the pulselessness because we already gave that to the students. No, I don't want sticky keys. You would take out chest compressions? Okay. That's a good point. That's a universal response to pulselessness. Yeah, no, you're correct, right? Pulseless patient, start chest compressions.
So if you want to recognition of being dead, then take her replicate. And you could add another, it might be too many medication, but you could add like atropine or something like that. But then you get that, too many medication options. Like if there's two that are too similar.
Yeah, so what's another good sort of tempting one? You like atropine? Do people think students would pick atropine? So there was a suggestion for a cardio version.
Well, what about attempting to pace?
Attempting to pace.
Pace your path.
The true correct answer. Yeah, or maybe like amiodarone. I'm trying to think like what would students do with like a wide complex tachycardia?
Alcohol withdrawal and like complex secretary.
Ooh, magnesium. I like that.
That's a good factor.
All right, so now we got a couple meds, a couple airway things, and defibrillate. I like that. I think that came out pretty good. Make those all look the same. So I'll come through and clean these up later, but something like that. No, that's a great point, right? That's a common. So the other part of that is when we pick a picture of it, we'll have to make sure that it's like very clearly, like there's no question that that's like, oh, it could maybe be torsades. Okay.
Then do you think like the range of the jewels will be the queuing? Just cause like,
Oh yeah. Do we really want to give a range? You want to just pick a number there? Yeah, I kind of agree with that. Okay.
It says 120 to 200, but it's like everybody I talked to was like, I always take 200, and I couldn't find rate space stuff for a while. So I don't know exactly. So that's what I taught my students. I'm like, you know what? We just do it.
My question is if the ACLS says start here and then go up,
Is it
if we say 200, will that do something?
It doesn't say start and go up. It says a range. It says 120 to 200.
Okay.
I mean, I think that also gets back to the question somebody asked earlier of like, does that rate of 120 beats a minute, does that matter, right? And for me, I would, as the tester, as the examiner, I would want to know, like, do they pick defibrillation, right? Like they might be like, well, I'm not sure about that dose, but man, none of these other things are the right thing to do. So I'm going to go with that 200. And I think, right, that's the level of knowledge that I want the student to know. Plus I'm worried if we just put defibrillate, like it's gonna be pretty obvious. So, all right. Well, so now we got 2 good questions out of 1 nice little stem, and you start to get a sense of just how painful this can be. All right. And then somebody picked this strip. What do you guys think about this?
Yeah, that's good because they'll think about torsades.
Yeah, because right, it starts off kind of coarse and it gets a little finer, but I think that's pretty obviously not torsades.
But it leads
Right.
so it makes them think about it.
All right. Does anybody have a problem with that strip? I think it's good. Whoever found that, thank you. Cool. All right. Well, let's look at another one. Okay. 45-year-old female gets stabbed. She's rushed to the ER. Vital signs with a pulse of 145, blood pressure is low, respiratory rates high, SATs are terrible. Put on a non-rebreather. She can speak 2 words at a time. So got a thready pulse. There's a great description going on here. Lung examination, absent breath sounds on the right. Is that the side she got stabbed in? Doesn't say. Okay. So we might need to clarify that. Skin exam noted. Oh, there. Okay. Laceration above the right nipple. So that's where we got it. Patient has jugular venous distension. What's the most likely cause of the patient's hypotension? Hypovolemia, cardiac injury, decreased SVR, diaphragmatic rupture, decreased JVP, increased intrathoracic pressure. What do you guys think about this one? Personally, when I first read this, I love this. I think there's one minor, very easily correctable flaw. What's that? No, I think that's okay, right? Because you're basically going through the different types of shock.
Do you need to clarify intrathoracic pressure or like on the right, or or on, if the stab wound is there, it's tension to the thorax.
That's what I think.
Can we just say increased intrathoracic pressure? Is that enough?
I think that's enough. My big problem is that we said that they have jugular venous distension, so no one is ever going to pick E. Right? Like, that was really the only problem I had with this one, is like, you can't have both high and low jugular venous pressure. So I think if we deleted this.
So I love this question, and the reason why I put that one in,
You didn't have to tell on yourself.
honest. Also, right. But now there's skewing, because now there's an increase and a decrease. So if I was testing it, I would say, hey, it's increased or decreased. I try to find something that's decreased to have a plausible description to use the wrong answer. So that's what I was thinking.
But it happens with stab wounds, right? It's a weird thing. I don't know. I don't love diaphragmatic rupture. Can somebody think of a different
So change the septic.
septic shock?
Mediastinal injury.
Ooh, mediastinal injury.
When you just change,
About spinal cord injury.
when you just change the location from right to left instead,
Okay.
because then now makes us direct cardiac injury likely.
Oh, that's a good point. The direct cardiac injury is more likely because of left-sided stab instead of a right.
Go up and get to the plan like diaphragmatic rupture and left and running.
Also true. Okay.
So if you
Anybody have a problem changing it to a left-sided stab wound to make both diaphragmatic injury and cardiac injury more likely?
right, just change and then stem to left.
Okay. I like that. That's good. Mike, to your point, I think sepsis is like, it's a classic shock answer, but like, that would be so weird from like this mechanism that,
Well, I guess, again, I would have to defer to the question author to really have a sense of what we're trying to ask here. What are we trying to test here? If we're testing differentiation of different types of shock, then I having something in there to kind of bring sort of perception sense. If we're instead testing what is under differential for a step, then diaphragm injury makes sense. So without that piece, I'm not sure that I know how to start changing that as a topic.
so what if I was trying to think if we got the word hypotension out of there, because I think when you throw in hypotension right now, you're sort of in the realm of what are the flavors of shock. And you're right, asking what's the injury that's caused this picture is a different question than what flavor of shock does she have.
But it's still a good, multi-level, recognize that shock, recognize that there's, pathophysics, or then what is the injury that pulls it all together, right? I know that multiple layers here.
Yeah, because I kind of agree. I don't think most students would pick diaphragmatic rupture as a cause of hypotension. And I'm just trying to think of how could you word the lead in.
Well, but then again, there's some students that probably miss that and not focus on the hypotension and instead, okay, got staff, what's in that area? So that's an unreasonable distraction. It's just, what is
The last one back, and then
What if we changed? Oh, you want the stab wound to be on the back? And so then you want to change which one to spinal injury? This one? Something like that. All right, so now she got stabbed in the back. Spinal cord is maybe a potential. Maybe a great vessel, maybe the heart, maybe the diaphragm.
The second sentence on the stem, is that redundant because you already said they present to the ED? You want to say they reference to the ED?
That's a good point.
Unless you're trying to say that she was brought by friends, not EMS.
I don't think the method of arrival really matters, right? Right, so that gets back to sort of unnecessary, complicated stuff. Like, I'm sure you had a real case in mind when you wrote this. Like, oh yeah, the drop off, that was a disaster. Yeah, and I catch myself doing that all the time, and it's good to have somebody else throw up objectively. Like, do we really need that? Like, but that was part of the story. That was the best part. Yeah. All right, so stab wound, right? We got these vitals. She's able to talk, thready pulse, so we know she's shocky. That's good. All right, absent breath sounds on the left, stab wound midline back. I think this is pretty good.
Now we're queuing the decrease and decrease.
I think that's okay because you have them both right in equal amounts. So I think that's okay.
When I look at this, I see like two questions which are asking something more general, like decrease sympathetic tone and decrease intrathoracic pressure, and three answers which are a little more specific injuries. Does that matter?
Maybe that is a good point.
Either like instead of splaining injuries or like hypotonia or aortic shock or blood loss.
I guess you could. I see what you're saying, and so I think maybe if we add both, right? So like blood loss due to subclavian injury, right? Decreased cardiac output due to cardiac injury. Decreased sympathetic tone due to spinal cord injury. I don't know how we make diaphragmatic injury work in that context. But I see what you're saying, right? We got kind of two.
I don't think you need to do two. You're implying that you need. I don't think you need to have.
But I think Tom's point, right, is that there's very specific injuries, and then there's sort of like pathophys, and we're mixing and matching.
But then maybe you go back to the hypervolemia instead of just the gait injury.
Okay.
And change D to decreased cardiac output. I mean, that's kind of should be the memories.
Yeah, that's right. That's where.
Yeah, I would change it back to either hypervolemia or acute blood loss. And then diaphragmatic, I think there's no problem with that. How is that complicated?
Something like that, maybe.
Yeah, I like myocardial injury or decreased cardiac myocardial abnormality or something like that, because that's the pathophysiology of like. I guess the question is, when you actually puncture myocardium, are you dying from blood loss or?
It all depends on if you get tamponade or not. Yeah, I mean it gets a little tricky, right?
I think you gotta change diaphragmatic. So that.
Well, so I guess the question I have is, if we change E to just tension pneumothorax, like does that substantially change?
But I think that's making it personal. We're trying to make them take two steps, right? It's like you have to think about what is the diagnosis and what is the pathogen.
Right, and so I think in the initial iteration of this, we were sort of mixing and matching, and so I guess the question is, are we going one way or the other way? We could do like we did with that first one and turn this into two questions, right? Where one we have specific injuries and the other we have sort of the pathophysiological consequences of those. Well, you could add that. Oh, I see. Well, let's just hold on. Let's just do that. Make a copy here. All right, this is probably the easier one to write, right? So now we turn this into massive transfusion protocol. Maybe turn this one into thoracotomy. I cannot spell today. What do we do for a diaphragmatic rupture? Right? Oh, thank you, whoever's correcting that.
Do you want a needle?
Yeah, maybe instead of chest tube, make that like thoracostomy or something, so it sounds a little. Yeah.
Don't we just leave the kids go class one?
I hate questions that
Yeah.
personally.
Most operations that be with their.
I know, but I think if you either then it's fine.
Should it be definitive management instead of next step? Because the next step, I would.
Well, you have to be careful about definitive, right? Because what's really the definitive management for this patient, like it depends on what exactly their injuries are.
You
And,
say in the emergency department, two thoracostomy is fine. You say they're like by EMS or something, like but you don't take pressure first.
yeah.
I think if it's somebody in the emergency department, then
Right. I mean, that's what we're teaching our residents, right? If your resident was like, "Oh, give me a 14 gauge needle," you'd be like, "What the fuck are you doing?"
yeah.
So,
And maybe there's queuing between thoracostomy and thoracotomy or no?
maybe.
But it's for
Yeah. I think-
Was it? So we say pericardial centesis. Yeah, I was just thinking that too. Yep. So change bead. Yeah. Right, and so this is a good example of like A is not wrong. You would absolutely do A, but that's not the correct answer. It's not the best answer. TPL. All right, so that was the easy one. So now let's go back up to the other one. I don't think DPL is anymore. They're teaching fast now. Uh-uh. Yeah, that came out with the 10th edition. That was like a big deal. Because they suddenly started tapping the ER people to teach ATLS again.
Yeah, actually,
I wasn't sure if they would still teach your things if you're teaching it internationally, but other.
that's a different scenario, right? You don't have those.
So I usually take some active there.
So back to your question, like an example of queuing would be if you wrote something like decreased venous return due to blood loss and decreased venous return due to increased intrathoracic pressure, right? That would totally be queuing. So that like that's where you really want to be careful is when you have answers that overlap that way of like, okay, well it's clearly decreased venous return, and which of these two is it? But so yeah, we could definitely say hypovolemia would be okay. So now we're all the way back to where we were before, right?
How about decreased what's it called? Like if you're thinking tamponade, you have decreased diastolic luxation or something. You know what I mean? Like something like that. Yeah, but you could actually say decrease like venture
Is that something like what you're thinking of? Well, I think we have to be careful about how we write this, right? Because if you say like decrease preload or something like that, like then many of these answers are right. Well, and you have JVD, but it could still be tamponade.
Why could you say, your fast exam shows decreased lung sliding on the left, which is following the most likely thing. Why aren't you? Is the next part is explaining the pathophysiology of pneumothorax, even the pneumothorax.
And you have to know what the lung sliding means.
Yes. Especially if you're doing it too hard.
I would also be thinking about that she able to see into like that but I feel like the main thing we want them to know is that she has no left on the left. And I feel like that's just an action that like has really come up with
I think thready femoral pulse, I agree with 1,000% because we already have this ridiculously low blood pressure. I think 2-word sentences sort of cues you that there's something going on with the lung.
Or that she's awake.
Also true. But I totally agree with thready pulses. So we want it. How do we want to say the lung sliding?
But if you know what that, if they know that lung slide, nothing else will matter, right? So as soon as you put that in, you can expect your answer.
Ultrasound, basic fast stuff is in the 3rd-year curriculum. Maybe. Well, Doug brings up a really good point, though. Like, if you know the ultrasound finding, then you kind of know the whole question. A chest X-ray is incorrect?
In the sense that if you pause to get a chest X-ray here, you shouldn't. Bad management. How about you say EFAS shows no pericardial fluid?
What do people think of that? Fast shows no pericardial fluid? Fast is negative? Standard fast?
For the question, what is in your differential or looking at the answer?
Well, I think that's the point Nate was trying to make, is like all of them, right? Except for, well, even diaphragmatic rupture is still in there, but it's not the cause of any of these problems, but it's certainly still in the differential.
If you said fast shows no free fluid, it's still, everything else there still works because you haven't excluded it.
Well, that's a good point. Because I don't know. Everybody thinks of fast differently, but for me, no free fluid would also mean there's nothing in the thorax to suggest massive hemothorax. So, what do people think of that? Fast shows no free fluid. Just leave it at that. I feel like that. Well, no, I guess hypovolemia is still on your list, but. Of like a heart with no fluid? How do you think? I'm trying to think. Because one of your objections was, could this be a massive hemothorax, right? Which would mute your lung sounds and cause you to be hypovolemic. Do you guys think your students could interpret, the thoracic gutters of a standard fast view? I don't know if mine could or not. Is that a fair student level testing point?
Do we know if there are your students taking this exam? Or
There are, unfortunately, there are third year students taking this exam.
I would imagine the first block, 30-year student will rely on that very.
Yeah. Well, the point that we make, though, is the exam is written at the fourth year level. It sort of assumes the knowledge of your core clinical clerkships, and and it's sort of on clerkship directors to decide, like, if I have a bunch of third years, do I want to sort of reset my expectations for exam performance, taking that into account? And that's a whole different discussion. But I think maybe let's table this question. I think it's a great STEM. I think there's potential here, but we've spent a lot of time on this one, so we're going to table this one and come back to it. All right, let's go down to another one. Or do you guys want to take a short break here, or you're enjoying this so much we love it? All right, 39-year-old female, shortness of breath, low blood pressure, tachycardic, hypoxic, EKG shows a right axis deviation. Oh my goodness. Okay. Okay, so what are we telling a picture of? Sounds like a PE to me. What do you guys think about this? I wish I could get this all on one page here. Let me. Where's the page break? I don't even know. Okay, there we go. So I think that's a nice description of a PE, but man, I don't know about these answer choices. And I feel like D really just sort of stands out from the rest.
Means describes when you look at the EKG, really describes right ventricular strain. No, it's just a test of whether you know something. You put clinical stuff around it, but that's basically the question.
I kind of agree with that, and I feel like that's almost no, I guess they don't come right out and say her EKG shows right ventricular stream, but
I mean, you're looking at it, you're trying to decide if they know the definition of right ventricular stream.
right.
That's really what the question is asking.
So what do we think about this as a testing point? Is this something we want to test? Is this like, I don't know, that students like, is this more than
Maybe it's an discriminator for those students who study and those who really study. Right? I mean, that's how you would distinguish maybe like this. If it was a really important test, you distinguish those who would do like did an honors versus I have.
I think this would distinguish which students did an ultrasound rotation versus which ones didn't.
I was thinking it's the only thing that they recognize.
Yeah, I mean, I look at answer D and I'm like, okay, it's not that because I don't even know what that is. So.
Even if I look at this, I feel like none of those other things.
Yeah, I kind of agree. I feel like this is sort of a test-wise student would probably figure this out.
That's what I was gonna say, is I think, like, you say the word right so many times, and I would look at me like, it's probably something on the right side. So I would have between A and B, and I'd be like, I don't know what A is, so I'm gonna go with B. I think we could,
But you make it a 50-50 question just by the right.
Yeah.
That's really, it's a two-choice question.
you could add a couple things in, like, say like something that you would expect a student to look for on ultrasound, like whole motion abnormality or myocardial pain, like wall aneurysm, or something that they hear about a lot because of MI. then maybe add a little bit.
I mean, I guess I would take that bigger step back though. Of like, do we really want to test students on the echo findings? Like, is that the thing that we're testing? Okay. You know, so like maybe we take this step and we just throw away the echo, or we give them, right? The echocardiogram shows right ventricular strain. Okay, super. You know, now what do we want to do? Right? We have this hypotensive young patient. You know, does she need ECMO? Does she need, you know, TPA right out of the gate? How would you treat this lady?
But activate cardiac cath lab, we could do a bunch of things.
Yeah, management, I think, is a little.
I'm taking the next step of figuring out.
Yeah, boy. Sorry to cut you off. You know, I think seeing that, right? If you put like new right bundle branch block, T-wave inversions, like those are words that are like MI, right? So calling the cath lab suddenly becomes an appealing option, in my opinion.
You were just saying about that echo part of it too. I feel like they use echo just as a kind of a way to kind of segue into the ideas of right ventricular strain, but I don't think we necessarily need that. Just what would be the expected cardiac abnormalities or something recently better. Because otherwise it does sound like it's focusing on echo, and when you see systolic anterior motion of the mitral valve, it's someone who's comfortable with cardiography.
Yes. All right, so let's axe those options and just say, you know, let's think about treatment of a PE, right? I didn't hear the last part of that. Do we think? Well, so that to me leads to the thing about distractors. What else do they do? What do you think they might think that this is?
Short breath. So right there is three positive things for E right there. And so if you want to add a distractor around, you're good. Let's just take one of those away. It's very hard to distract.
Do you think if you have like her medications included, it would like be too easy? Is that what y'all are saying?
It would certainly make it grand. I think, like Tom was saying, there's a lot of detail here that most students would get to PE from this, I think. But you're right, if you add more information, that will make it an easier question. That's not necessarily a bad thing.
So the goal is to make the management and the choice, then you don't want the diagnosis.
So that's true, but I also think, you know, like part of this is getting to the PE in the first place, like, and that's that adds to the difficulty of the question. So, you know, quick show of hands, like how many people think their students would have trouble getting to PE from this level of information? Like I think my top students would be there. I think my lower students would maybe struggle a little bit. I think my average students, I don't know, they would probably get this. I don't, you know.
Once you throw in that RV strain, it's more clear.
What if we gave her chest pain? Chest pain and shortness of breath? Would that help? I don't want to make it too obvious, but I agree. Like, there's always hard.
Chest pain was what I was thinking too. It just adds a, like once you say the word
Like sharp
chest
chest pain or something?
like we all know that's an autonomous differential and thinking about that.
What is?
It still could be a pneumothorax though.
Yeah, it could be. But pneumothorax, right? Pneumothorax shouldn't give you RV strain and EKG. Like I feel like when you put all the pieces together, it's all there. But I don't know. But I like adding chest pain because that helps with like the cath lab as a differential, right? Cardiac stuff as a differential. How about if we give her right-sided chest pain, just chest pain?
shove the innate done here, we'll be able to recognize the term of our future.
Everything is any possible demonstrators is not going to but
They don't like it.
even then, yeah, why the other thing is integrated foundational curriculum. So they might have some last concepts already before they will start. Not necessarily the same for March.
So the other tricky thing about writing a question like this is, you know, she's sort of heading towards that massive PE territory, and I don't. Everybody's hospital is maybe a little different about that. So do we feel like is she clearly in the realm of massive PE where she would get a lytic?
I would be under consideration, for sure.
Yeah, right. You know, because it's like at some hospitals she might, you know, if we make heparin as the right answer, some people might disagree with that strongly. So we're gonna have to be careful about what our answer sets look like.
And then cath lab, like cardiology will do the breakups, right?
Oh, that's a good point, right? So we can't just say cath lab. We got to be more careful than that. Right, so you might want to say something like that so it's very clear about this is what we're calling the cath lab for.
Except for the RV strain, could this fit with anaphylaxis? Could we be thinking
It's I don't know that many students would go that way, but I think, you know, seeing somebody who's hypotensive and hypoxic like epi is always a tempting choice in that scenario. Having watched my students in the sim lab, right? Like that's a thing they grab a lot. They like it. Ooh, pericarditis. What do people think about pericarditis as a possible? What are you guys using? Is anybody using colchicine for pericarditis or? Okay, a couple of things for antibiotics. So, all right, but we're still back to the big hard question of like, what are we giving her for this big? Should we make her less sick?
I mean, your next step for this patient is gonna be oxygen and maybe a little fluid bolus, even if you're gonna go towards TPI.
Okay. So you can do one of two things. You can either add that prior to the lead-in, right? In addition to oxygen and fluids, what's the next one? Or you can just not make it a choice at all so that it's not, right? Because if you put that in there, but it's like, well, they should get oxygen and heparin, like, so you just be careful about how you add.
Are we trying to hear the treatment of massive PE, or we're trying to get the diagnosis that this is PE? Because if it's just the diagnosis, then you get the everything, whether it's massive or not, we're all getting it.
Okay, that's a good point. So I think it was just you recognize this as a PE and you know what the treatment is. Not, but what I was trying to say is we have to be careful that somebody's not like, well, it's a massive PE, so they should also get, you know, this, that, the other.
Which is an appropriate next step in treatment, not maybe the quote.
Yeah, that's it.
And then you add
NDME would never let that one fly.
heparin or something like that, right? Like that's still on your treatment algorithm for big PE.
Yeah. My problem with that though, because like if I said the next step, I would look at this and have a problem with them. Like I would want thrombolytics. Like I don't want any of these. Because heparin wouldn't If she's got a massive need, she needs something more aggressive.
And what if we made her blood pressure better?
Yeah, so we have to make.
Right? Like maybe we make her a little less sick. Something like that. Oh, and we don't have a pulse. She probably should have a pulse, huh?
Yeah, but you got EKG.
Okay. And we said we were going to make this a new right bundle. You want to make the SpO2 a little higher? I think 90. Okay.
So she's borderline. She may not be sick enough to.
Now do people feel better about heparin as the right answer?
The army straight should be like TPA, right? It's not a salad.
If you're gonna leave coronary angioplasty, then do you need another diagnostic model like echocardiogram instead of, I don't know, some
Say that again. Do you need?
You've got everything else is a treatment, and then you've got angioplasty. Do you want to then instead replace one of the other, with something like pericardial, urgent or cardiac ultrasound or something? I'm looking for like pericarditis.
Yeah, I think what he's saying is these are all medications, and that's the only one that's not.
Aspirin. Oh, yeah. You know, antiplatelet agent.
Just aspirin? Yeah, I guess aspirin is definitely not the right answer there. But then we have to be careful about NSAIDs, right? Because aspirin is an NSAID. Yeah, so I think we leave colchicine there. All right. What do we think about this one?
Is there any algorithm in which Murphy straight, even with these vitals, the baby will go towards the end, you know?
So at our hospital, it's RV strain, hypotension, and an elevated troponin. And I don't know how everybody else, right? This is, like I said, this is at the NBME where we all look at each other's side-eyed, like, I don't know what you cowboys are doing out there. So just sort of think about that, right? But those are good questions to ask of, like, would anybody fall somewhere else, right? Because students are going to do what they see where they work, not what the textbook says, so.
And this is a totally different question for clinicians than it is for students. But, you know, so for students, you want to keep it as straightforward as you can in terms of vital signs.
I think it can be variable depending on their shock. You might use heparin, TPA, et cetera, but what do you agree on heparin? So I think that's fair to
Okay.
do heparin with this.
Is it the right ventricular strain that's the problem?
Yeah, but I think you need that.
You need that to do heparin versus have like,
I think that's the discriminating.
Yeah.
like that's,
I
I think that's
agree
what
too,
it's
it's
a
like-
higher risk of fruit.
Okay. Anybody else have a problem with this? We're good with this? We're like 5 questions in after an hour and a half.
There's too much right.
Oh yeah, hold on 1 second.
Ask the students if they correlate the symptoms with the EKG and then determine what they see on a program. And admittedly, we're lucky enough to start ultrasound training in 1 year, so that's kind of a context there. But it was really more about can you match the presentation with physiology that we see on a program, not the training, which I should stay away from because where I work, this presentation comes in and I call 30 people and there's like 10 different treatment options and there's things, you know, it's a mess. So I felt like the management of this type of fatigue would be a much more difficult question than simply what do you see on the study or how do you correlate your data and diagnosis. And not that I don't like the question at all, but it's asking very different things.
So I think, I mean, I hear what you're saying, and I think that that's a good question to ask, but I don't know that students are getting enough ultrasound to put that, like, to write that at a level where most students are going to be able to get that correct, or at least, say 2/3 of students are going to get that correct, it needs to be so basic that it's very obvious. Like, I think that was the problem, was the way that was written. It was like, I don't know how else you could have these answer choices and make it reasonable, but
The SAEM curriculum is very hard for the students and studying in a different institution. They have even a PE that didn't work right in that direction.
okay. But yeah, I'm actually with you. We have like a full PE and a modified PE, and you call different people. And like, I know one time we called like the modified PE, and this guy was like, "I'm driving down the Pacific Highway. Like, all right, you guys do what you want." So, it's just a mess. So, yeah. But that's a bigger, deeper question of like, how much ultrasound do we expect students to know? Like, I know everybody pretty much expects them to know fast. And I don't know much beyond fast. Like, we do some ultrasound with our students, but how much they get is kind of variable. It sort of depends. Like, if they're with one of our ultrasound friendlier attendings on the days they have procedure labs, they get a lot more. So like, how much cardiac ultrasound are people teaching? I don't know.
Like for us, there's like our stream.
None whatsoever. Okay. Right, so that's the other problem, and like I said, that's why groups like this, where we come in a room together from a bunch of different shops, and we all are like, "You guys are doing this wrong." It's helpful because it helps you sort of realize, what you think is important, or what is critical in your curriculum may not even be at somebody else's curriculum, and that's tricky. But I mean, I don't know who's working on the part of the ultrasound part of the CDEM curriculum. Is anybody working on that?
We're just gonna put the list of topics.
Right, because I think that's gonna be a fine line to walk, right? Because if you get some like really ultrasound interested person, they're gonna be like, of course students have to know all this stuff, and then you're gonna have some poor other guy who like does no ultrasound. It's like, I can't teach all of them. So we're gonna have to be careful as we develop that curriculum. All right, let's keep moving on. All right, this was oh, this is not the one that I was thinking of. This is another PE question. Okay. The PE curriculum doesn't even mention ultrasound?
It varies in disposition, it varies briefly, but it's like diagnostics, and it has like the PG, it has duplex on the legs, but it doesn't have an echo. And I feel like it probably should have an echo.
Probably should have that. Keep taking note.
Oh yeah, sorry. I was thinking.
No, she was saying that currently the PE part of CDEM curriculum doesn't even really mention echocardiography as part of the.
It's like very, very, briefly mentioned. I feel like we should almost not with some, as an EEG scan. Yeah. She's like, well,
I'm gonna give you this. I cannot hear you up there. It's like so loud against that wall. There's like so much stuff.
Oh, thanks. Yeah, those ultrasound people are having fun over there, huh? No, what I was just gonna say is really more of just like a philosophical thing, because I wonder if saying like on an internal medicine test, management of a PE is heparin, right? But if we're focusing on the emergency medicine aspect of that, I really want my students to know the difference between a not so massive PE and just like a normal PE, right? And so testing them on a normal PE that just goes to the floor and gets heparin, that's not really something that I'm interested in, on the test.
So on the one hand, I totally agree with that. On the other hand, I think the biggest problem is that I don't know that it's really been standardized what makes a massive PE. Unless it's like
no, right. So
unconscious, no blood pressure, nothing, like where it's like, okay, duh. But
so we probably wouldn't have a question on exact definitions of that, but more so, can you think about that differently, or do you understand a different approach to that? What? Yeah, or something, or
Well, and again, I hate to come back to ultrasound, but for example, on the floor, if somebody has a PE and they're admitted on the floor, getting an echo the next day is fine. But why, in this context, in this curriculum, do we want you to know to do an echo right now? It doesn't have to be an echo necessarily; it can be some other intervention. But I mean, I guess the question, the point of the question, I'm just wondering, how far do we want to stray from emergency management evaluation just for the sake of coming up with a good question for a student?
But I think there's a huge variation in emergency management, and I think that's part of the problem.
Yeah.
But the other problem is, who's your learner? Is your learner a student who's going into emergency medicine, who's going to apply pregnancy, versus somebody who's going to do paper practice, or OB-GYN, or whatever? You have all the students.
But you want, even though the students are going through a different practice, you want them to know, hey, at least how you do an emergent PE. I mean,
Do I want them to know that? Do I really want them to know that? Do I want my pediatrician to know that? Do I want my OB-GYN?
at least they know what the treatment would be.
I would want them to recognize it. I would want them to understand that's what's going on. I'm not sure I would want them to treat it. I'm not sure my risk management people would want them to treat it. That's kind of, I'm not saying there's a right or wrong answer here. I'm just thinking those are things you have to consider.
That's a good question. But I think going back to what Nate was saying is, do we want students to know, like, how do I distinguish a garden variety PE from a massive PE? And I think that's a fair question to test. And so, you could have a scenario like this, right? And then you're like, well, what tests do you need to diagnose this? And maybe the right answers are like echo plus troponin. I don't know, like, what are your other choices along that axis? And that also becomes hard, right? Of like, I got this great concept, I got my question, I got my right answer. I need 4 more answers.
Give you an example. They developed the first selfie kit. ABME had all these item writers. The ABME had all these item writers come in for emergency medicine, and they had a question up there, and it was a question about treatment for headaches. Okay, I think it sounded like a vascular headache kind of scenario. And everybody in the room either chose something from their shop, either morphine, Toradol, Reglan Benadryl. Those are all choices. But the answer was a triptan. And the woman who's doing this thing, looking at all this educator, says, well, this is actually on the ABME, and 7% or 80% of the students got this correct. And we're like, what? And when they looked at our thing around there, most centered around Reglan Benadryl, Toradol. And he's like, you guys are educators, but yes, this is an actual exam on the ABME, and you guys only did worse than the med student. Turned out there was a triptan. It was just a general question, probably written by a neurologist. So for that test, the correct answer, I was like, well, are you going to change it based on us educators? And he's like, no, we're not changing it because 60, 70, 80% got it correct. And the bad students got it wrong. I was like, so we would be bad students on this regular national board ME exam. I'm just saying that as just a classic example of, well, which specialty you're from, and your answer may differ. And who's it approachable for? Now, I was saying that for us, we're doing a CDEM test geared for students in emergency medicine that rotate through. They're taught a PE, yes, but it's just like they're taught what an MI is, but they got to know, hey, are you going to cath them? You're going to thrombolytic them? Same with a PE. Are you just going to heparinize them? You're going to give them thrombolytics? You're just going to give them oxygen? I mean, I don't think any medical school in ER curriculum says, oh, here, diagnose a PE. No, don't worry about the treatment. They just need to have general, they don't have to know dosing or anything, but have a general idea what they're going to do. The more massive it is, the more likely you're going to go thrombolytics. They code. Some people maybe even do a crack open the chest and massage the pulmonary embolism. I don't know.
Yeah, this is it's tough, and I think where you fall on that spectrum probably depends on who you teach. So, do you have is your clerkship, is it elective or is it required?
I've been out for a while, but where I was, it was required.
It was required.
Yeah, 10 years ago, whatever it was.
Because I kind of agree with Tom, that like there's sort of this general set of expectations that, I sort of think about it as like a NBME step 3, like, do you recognize that this is a problem and needs to go to the ER? Can you institute some sort of basic treatments to get the patient where they need to go safely versus like, do you really want to get into the nitty gritty of how to manage this? And I don't know where on that spectrum, like, I don't know that we have as a group of people have really answered like where on the spectrum this exam needs to be. I think it's okay to have some questions that are very general and some questions that are way more specific, and that helps sort out, I forget who said it, the kids who are studying versus the kids who are not. But that's, that goes back to all the way back to like the first couple slides that I was showing, right? Of like, what's the point of this exam? What are we trying to do with this thing? And I think that's hard given we have third year students, we have fourth year students, we have required students, we have elective students, we have students who are going to do 5 rotations, we have students who are only going to ever do 1 rotation, and man, it gets tricky.
And that's why the student update we're doing, we're trying to create a single body of knowledge that we spend every student going through an EM first year, regardless of specialty, and they should learn on that question. And that's why this curriculum update is what we're trying to do. Right now, we have an N4 curriculum side for students to get N4, and N3 curriculum, and PEDS curriculum, all those fair. But we believe that there's a core body of EM knowledge that every student and I hope that these questions will reflect that. That's nice.
We may be changing that.
We can currently update you, right? We're like topic first, and then we can do it. But I heard the curriculum, PPA for massive need.
All right. Well, if somebody can think of how to write that question, right, of like massive PE, what do we do? Or do you recognize this is a massive P and know the next day, what the question you're trying to get, like, think about that some more. Because I think that's a great question. I don't know how to write that question.
Sorry, Doug, I'm not really trying to sabotage your whole thing here, and I'll shut up, I promise, but allow me one more tangent. Years ago, we used the script concordance test. I think you remember that, right? And yeah, I mean, one of the reasons why I liked that was because it was not this knowledge recollection. It wasn't this, multiple, which arguably we're stuck with, we have to do, but it had more of a, how do you make a judgment call? Like how does this differentiate this patient, in a clinic setting versus an ED setting, or what factors would you be looking for to approach this differently? And I'm just wondering, should we try to figure out how to write that into a multiple choice test question? Have more of the not what's the next step or what's the next best thing. Instead, what would change your mind about doing this, and then have some options. Like, has anybody looked into that?
Not that I know of. So just for the room, how many people have heard of script concordance testing? So this is a fascinating testing modality that a guy named Bernie Charlin came up with in like the early 2000s. And what he did was he would write a somewhat nuanced and vague clinical scenario. A person comes in with shortness of breath, and basically the lead-in would be something along the lines of like, which of the following pieces of information would make you more likely to, and then for let's say a PE question would be like, give this patient thrombolytics, and then and the answer choices might be like a chest x-ray, an EKG showing right ventricular strain, an echocardiogram, a troponin of 17, whatever. And they would give those answers to a group of, you would have a verified group of experts, and you would see how the experts answered the questions, and then the students actually got points based on how well they aligned with the experts. So like all of those answer choices might be correct, but they might be more or less correct. And it was a really interesting modality. I think the problem with the multiple choice testing, right, is you get to pick one thing. And so it's really hard, like you can't, it's either right or wrong. It's very binary that way, right? But you could certainly write a question in that style, right? Of like, here's this patient, And you make it very obvious, like, okay, they have a PE, right? Much like we did with this one. But then you maybe ask, like, which of the following tests is most likely to confirm the diagnosis? But even that gets tricky, right? Because maybe their echo is not the right answer. It's actually CTPE. You know, so yeah, I don't know. I don't know how to write the question that you're trying to write.
What if you said which of the following put in combining to make you likely to get wrong limits? Should you give them
Well, you can't ask it that way, right? Because to make you likely might be different than makes me likely.
Like make it obvious, like you know what I mean?
Is that obvious? My administrator says inception.
Yeah.
Right? I mean, it's, you know, with the script concordance thing, I've seen them use that, like, instead of drop, like, you go further down, take a choice, and then goes to the next question, and there's another set of choices, and things like that. And it really gets to the real understanding that the student has from what you're asking about. It's just a real pain in the ass, right?
Yeah.
But it does discriminate really well, especially for things like skills and things like that too.
Yeah.
If it's worth the effort, you consider that for some of the things.
I mean, I'll admit I'm biased because I really like that exam. But you know, I think that could be an interesting approach to take. And I guess the software, all we'd really have to have is a way to partially give points, right, for responses. Isn't that how that worked?
Yeah, I mean, when we were doing the script and chords exam way back when, I had like this giant ass Excel spreadsheet that sort of did it
Right.
for you.
But they still,
It's a huge pain.
but they still picked
But
one
it was
answer.
cool. It was
Yeah,
cool.
it was still picked, you know, A through D,
Yeah.
and just scored on the back end differently.
Yeah, maybe it's time to write that.
And then, yeah, because I think it'd be interesting to have like a group like this, you know, come up with what they thought the right answer was and use that as a reference. All right, sorry,
That
Doug.
was one of the flaws of the script concordance test, though, was that you had to be really careful about picking your pool of experts.
Yes.
And that if you had too many questions where the experts were sort of all over the map, then you didn't really get discrimination against students because, you know, if 20% of the experts had picked each of the 5 answers, then it didn't matter what answer the student picked. They were equally close to all the experts. So that was a minor flaw. But my brain keeps kicking this around, you know, so you could ask a question of like, you know, which of the following helps determine whether or not you would give TNK or something like that, right? And again, you'd have to be really careful about what you find. And maybe there you list specific findings, you know, subsegmental PE on CTPE, right? Ventricular strain on an echo, a massive DVT on a leg ultrasound, you know, stuff like that, where maybe that's how you could write that question. I don't know. I'm going to keep turning this over. And then I'll come up with an answer and I have a horrible flaw. But so, you know, again, that goes way back to like the part that I was saying of like, sometimes you have a great idea and turning it into a question is just like, I can't do this. So, and that's what makes this hard. All right. So we got this is another PE kind of a question, right? And then now the patient goes into cardiac arrest. What are we going to do? Well, their TPA is the right answer. Whew. All right, what do we think of this question? I'll let people like read it again.
Is the horse mine because
Yeah, we got a swollen leg. 4-day admission for hand set legs.
No matter how hard the question is, it's really hard.
That's a lot of information in that stem.
You really even need all the vitals. I mean, just basically the history of the bedridden and now was with the cardiac arrest. And with the HV, all the others are just like that's
Yeah, I mean, he looks kind of shocky initially, And I think that makes, like infectious sort of stuff more likely, but I don't know. I'm just trying to think of how to pare this down because this is a lot.
So, one thing I do know is that if you had a short stem and a short answer, more people can find the answer. If they need to question, like I said, we import the question, so more people can miss it, and more bad testers can pick the wrong answer, so we have to let a question. The good candidate versus the bad candidate. He just Lincoln the scenario. Lincoln, Lincoln found out that West, that they was always surviving. They were able to pull down on what's really important.
Yes.
Want to be, oh my God, this guy, they get off, focus off, they get all jumbled, they're confused, and that's why. The option, you can get that choice back and say, oh, this way, then you realize your choices, the ones that nobody picked it for, people start picking this.
Right. Well, and that's because you're adding stuff into that stem that makes those things more likely, right? Just like we did with that very first question of like, let's make this guy twitchy, so the lorazepam seems like a good answer.
Yeah, but that's what I found out when they sent me back these for the national award.
Yeah. Well, no, because if you write, if you just write those very recall kind of questions, right, the one-liners, then you're right. Like either the people that know it are going to get it right, and the people that don't aren't. And so by adding more detail, you're trying to make students have to actually think about it, and you're turning it into an application question instead of a pure recall question. That's the goal of that.
That's what I found out.
All right, so I guess the big question, right? What do people think about this question first of all, right? Guy who very clearly has a PE, goes in the cardiac arrest, gets TNK. Like we like it as a question, it's a concept. This gets back to what Dr. Lewis was asking. People cool with that?
Very long.
Yeah. Well, that's to me is part two. Like, is if we don't like the question, workshopping it is pointless. We'll move on. But I think we like the question. What were you gonna say, Nathan?
Well, I just think, I think the way I read this, the first several sentences are setting up the plausibility that this is a PE, right?
I think so.
Yeah, that I think that's the part we could probably leverage from, because by the time we get to the clinical findings and then the rest, I think it's opposite that point is where we're headed. So I don't even know if you need a admission. I don't know if you need a history, honestly, unless you just want to keep it consistency. Vital signs you need, regulated findings you need. Taking that one in a row probably is not relevant.
I wasn't sure if those were maybe there was like a distractor, because you're asking them about H's and T's, and so you add an ACE inhibitor, are they thinking hyperkalemia then, you got that in there? And I think,
You want it? Why do you want to leave the cellulitis?
well, I don't know if you need the cellulitis, but I think the admission does help, just because I found that there's a pretty high barrier when it comes to like beginners in ACLS with actually getting TMP there. I feel like it takes a lot to get to that point. They really need a lot of context clues, so I think it does help a little bit. But it is.
I'll just note that none of our answer choices play to sepsis, so I was like, I don't think I need that piece of information. Right? If we were going to throw an antibiotic in there, okay. Maybe. So we'll maybe come back to that. So and then we have the tenderness on the right leg. So like that's coming in the physical exam, so we can get rid of that. Okay, hold on 1 second. I'm going to take the heart exam, right? Because we get that he's tachycardic. They've already given us a pulse of 120, so we don't really need that, right? And then, sorry, you said take out which one? I'm hearing mixed opinions over here. What do you guys think? Leave the metformin, take it out?
It's probably unnecessary.
All right.
Metformin, unless we're going to add anything after that, is this is an acute onset in the breast now. what is it you say?
Well, were you saying earlier even because it implies acidosis?
No, I was saying like if you're trying to like lead someone into it, like where am I going with my H's and T's? You might push them towards calcium when they see glycidopril. It's not a strong push. I'm not suggesting it's.
That's what
I think I would abandon it to make it less.
Yeah, I don't think it's that robust. I would just.
Still even take ACLS. Also, last week. Yes.
We're all in agreement to take out the metformin and lisinopril.
Put them on Dewey instead.
Eat it.
All right, I think we chopped a lot out already. I still think it's long, but
This would be 1 week. He was recently discharged from the hospital 1 week ago.
oh, you're right. Sorry.
It's like 1 week in.
So, and in fact, we can take out just recently, right? He was discharged from the hospital 1 week ago. Whoops. You got it. Thank you.
Aspirin is not a good choice. It's one's really arresting the ACLS, everything all away.
I kind of agree with that.
They take that.
You've got another item on the beds later.
Put the word radical in front.
So scroll down a little bit. I don't love this set of answer choices, but
Happy.
But he said, well, but you don't need it to do have
ACL
condition following
protocol.
ACLS protocol.
Yeah.
Which I feel like that takes out the art.
Yeah.
Yeah. I'm not sure. I mean, yeah, LASIK doesn't really fit in with this unless you're thinking the market of your, and the acuity is mixed. I mean, I would almost even put it in something like Mango.
yeah, I think having TPA and heparin, I feel like you sort of.
I'm serious.
What was that?
It's not tracks. You're saying it's not fit or something?
Yeah, I want to take out heparin.
He's hypotensive and tachycardic. Like, what is this picture before he goes to the cardiac arrest? He's hypoxic, hypertensive, tachycardic.
Not a bad, but maybe it's healthcare associated pneumonia. So maybe
Right.
He's just in the hospital.
When you go in the sepsis advisor, what are they gonna tell you?
Yeah, what is the HCAP therapy these days? Or HAP? What are we calling it? What are we even calling it right now?
I think we're just having a baby right now. Subtraction. Subtraction and then throw something. What other weird things can you come up with? Magnesium.
Magnesium works. Oh, yeah. That's a good choice.
Yeah, I like magnesium. I don't know that. I think people would pick one or the other. Well, I guess you might pick both magnesium and calcium. But.
Albuterol.
I heard,
Yes, it's an ambio. I like ambio.
I'll take Amio.
Yeah, that's because that would be right.
If you're confused at A and B, you're gonna split students.
Yeah, I think having both A and B is problematic. Even though TPA is clearly the right answer.
True. I think most of my students, when I quiz them on this, like SimLab, do say heparin before they say TPA, but it's definitely the wrong answer. So that's just too hard of a question. Then we,
I don't. Do you think it cues though to have two like sort of blood clotting agents, and then you have this other sort of I don't. Right. That's always hard for me as a person who clearly knows what this question is about. But
Or you could have magnesium have three electrolyte answers to which one's the right set.
I sort of, the more I think about it, the more I like Sarah's idea of an antibiotic of like this person was in the hospital and it's low grade fever. And
Norepinephrine. Norepinephrine.
oh, norepi. That's not an antibiotic.
You're thinking sepsis?
I like norepi.
Someone said your entire real name was even if you're following ACLS protocols, you would use this.
so you have my hand, it's a very accurate answer.
Yeah.
Except for no, it's correct, the rest are kind of.
So I think question one, what do people think about having both TPA and pepper? Everybody okay with that?
I think it's probably a last answer.
I think it's huge.
People think it's okay.
It does.
All right, so we'll scrap heparin. And then somebody said norepi, which I love.
Then all your answer choices are ACLS treatments.
Is bicarb still in ACLS?
I mean, it's not direct.
Not enough.
But it's in the book. And then
I think observation we all have seen it given some time.
So are you saying that's a good thing or a bad thing?
You're saying in addition to the following ACLS protocols.
What's your differential?
Yeah, because those are already in ACLS.
Yeah, and they're all ACLS options.
Okay. So change, what am I changing here? Furosemide at this point then?
I would choose furosemide to magnesium and norepi to antifibrillary.
Ooh, lidocaine. That's one of those ones that messes students up.
Totally. That would be very.
I think norepi should.
So you don't like the sepsis idea?
I would like to think that if someone had cardiac arrest, they should not be treated the same.
They're all just gonna cross.
I guess that's a good point. Once you start ACLS, you're right. Like,
They're all gonna cross lidocaine off right away.
Yeah.
so you think Ambio is a better option?
I think Amio's, yeah. If I associate
You've never seen lidocaine given.
That's still an
And
ACLS.
well, they've seen it given when they were repairing a lack.
Yeah, exactly.
What if we just take out the line that says in addition to following ACLS? Just start at.
So you can just say ACLS protocol started or something like that.
So then I think you're thinking happy.
Well, I think number one, right, it's trickier to make sure we're getting things excluded, in that sense. But secondly, do students have panics? Do you think they maybe perceive this as like a fair question?
Well, you could just say in addition to IV epinephrine, which is the following is.
Chest compressions and epinephrine have been given.
Right.
Epinephrine has been.
Take epinephrine
chest
out of
compressions
your
have been
mind.
initiated. Now what do you do?
Yeah.
So there's five ACLS, but they haven't had it, so.
We just think it's still.
Because now it's making reduction piece of thinking.
Which of the following is the next most of the group?
I like that.
You know, include a bad valve mass ventilation or CPR is initiated.
Well, because we're just talking about.
Well, the question's
Well,
solved.
that's it's bad, you know. Person's down behind it. That's what you want.
Using CPR and then.
I like this better. I still worry a little bit that TPA is kind of stands out from the rest of these. But I think for students that don't really know ACLS, like we know ACLS, it's probably okay.
Yeah.
And that's, like I said before, that's a hard thing to do. Like put yourself back in like fourth year medical student mind frame of like what you didn't know at that point in time. All right, we like this one?
Better.
We're like 6 questions in and we're killing it. Yeah, we're doing this all week. You guys are trapped. I locked the doors and ration the snacks because that's all we get. All right. It's the kind of question I love to write. 2 reasons to be Disney. What are we gonna do? All right, the one problem I have with this, so B and C, we got ventilation in both of those. I think B is the correct answer here, right?
Yes.
I want you on yours, mine. Oh, it's there.
We got it there. Sorry, let me yeah. Delete C. Anybody have a problem with that? I kind of agree.
You want to throw in a history of CHF and COPD coming in with cough, you're going to have to take an antibiotic.
Ooh.
Something there that gives you the moment.
I kind of agree.
I also like, I think all the answers are very different.
Yeah, so this gets into that, like we got like a diagnosis and a treatment and a medication and a so I think blood gas kind of sort of stands out.
You could do a blood gas and get an EKG or
Okay, I think EKG at least makes more sense than blood gas, although is it long? So one of the things we'll sometimes do with this, if we have a couple of axes like this, is at least try to make it so that there's an even amount of each. 2 treatments, 2 diagnostics, something like that.
When I kind of coach students, for example, in the exam, and talk about what they should think about, I say the first thing you always want to do is stabilize and unstable vital signs. And I feel like what you said at 88 is going to drive them towards the ventilation. But maybe
Except they also all like buy into COPD 88%.
yeah, it's true.
Says that, but not the unstable. You know what I mean? Like
Do you want to make her stats slightly higher?
89.
Right, because I mean she's still working really hard. Yeah.
So I think you could
Like her stats are not what's driving my intervention at this point. So we'll make that a little less obvious.
Confusing thing for me about this question is that we're trying to get an answer that suggests escalation in treatment, and the step doesn't necessarily give you that in the first glance. If you were to assume that the patient's like stable, I'm not suggesting they aren't necessarily, like antibiotics can be a real thing. What if we change the speaking in one word sentence to giving counter muscles despite receiving albuterol or something?
Yeah, or she has received, a treatment of albuterol and it's not approved. Something that's she's refractory to the albuterol. That's a great.
you could put she's on 3 liter or 4 liters nasal cannula or something.
Something. Like her stats 90.
Whoa.
Well, we related.
What? I do not like this computer. What I was gonna do, right? Because I don't care if she's oriented times 3.
They may care for like whether you put a hat on or not though.
Oh.
So just in the sense of like they're not older. Yeah, she's older.
How's that?
And you don't need to say she's receiving currently receiving.
Right.
You can say I would probably still put something that she's on still on.
Yeah, but there's something that makes her breathe because she's refractory and sick.
The oxygen is not the answer.
I would take like comparing diaphragmatic, extreme as extreme.
Say that again.
I think she's comparing diaphragmatic on exam.
Sarah was saying she would alert just so they quite have the same option as zero. But on these wire are still wire.
The patient is alert, but. I don't think one word is.
One word. For a basis. Right.
Yeah.
Trying to figure out how to put alert in here. Yeah, I sort of feel like speaking implies alert, but
I guess if we're trying to say she's not confused, but I think we can assume that.
we got these two treatments here, and the rest are, or sorry, two diagnostic studies, and the rest are treatments. Can we make them all treatments?
Yeah, you can give her steroids.
Oh.
Nitro.
Since you have routes for DAH, you get like initial IV.
Within your non-invasive, the only thing that's an intervention. It's not COPD.
Oh, that's a good point.
What else did we do to her? What did chest do?
CT and.
Elevator killer bed.
Helios.
Oh my god. Oh my god.
Antibiotics?
No, that's a
You prefer an upper breather initially. I prefer an optic initially, but an upper breather. And then we work so much.
Oh, yeah.
Or like increasing giving you oxygen.
Yeah.
I got her oxygen.
Call this kid.
I think I missed it before. What was wrong with the CTA and blood gas?
Well, we were trying to get it so that we had all sort of treatment options instead of a mix of treatments and diagnoses.
Yeah,
Why is that not a letter?
upper breather would make her not hypoxic.
So you want her even less hypoxic.
And escalating the oxygen is not the answer, it's escalating the ventilation, right? And you can differentiate it that way.
Yeah, I mean, I kind of agree, right? And that's what I was saying earlier. It's like the oxygen is not what's driving this case, and I feel like students, or at least in my experience, are often reluctant to do oxygen stuff with COPDers.
Question, can you have administered in front of both B and C, initiate?
Yeah, probably initiate something like that. Yeah.
So if you know, administer or initiate, so just data, so administer, initiate, administer, initiate.
What if we went a slightly different direction? Maybe she got albuterol by EMS, and then it's like give her more albuterol.
Nobody likes that.
What's that?
Rewrite as a script report.
Yeah, I know, really.
Why would you do this versus that?
But you've already said you've already given us 3 doses of albuterol.
I know. I was saying like, but maybe back off the albuterol.
She's failing in the ED, right? She's already had multiple meds. She's diaphoretic and anxious. So you gotta do something.
Anti-anxiety.
Ooh.
And that's why in my mind, initiating nitro doesn't, and even antibiotics.
Except the CHI will trigger them for that,
Right.
right? Did you leave your point on? Or you took it out?
I think we took it off. We could certainly put that back on. Oh no, it's still there. It's okay to cue wrong answers. That's totally fine.
Oh, really? It doesn't knock you out if you say.
No, because they're right. They're different. They're different things. Although you're right that most students would be like, those usually go together, and they're not together right now. Ooh, terbutaline. That's old school. But so I heard somebody say heliox too, and that was one that came to mind for me. And I'm like, we never do that. Like, students would be like, what is that?
We have to find the machine. It's self-deposit.
Yeah, yeah. I remember where we did residency, there was always that big tank. It was like in the corner of the ER. You're like, what's that for? Oh, it makes your voice all funny.
I just want to bring back into me.
Bring back intubate.
Do we need to be more specific with non-invasive positive pressure? Because high flow technically is positive pressure.
There's something not
High level.
like not or 7.
Yeah. In some predictable elimination.
Yeah, well, so the problem with intubate, Sarah, was that we had the word ventilation in there, and so I think, if we took that out, right, so maybe you change non-invasive to like bi-level positive airway pressure, and then like endotracheal intubation or something like that, yeah.
I just feel like it's a tempting answer, which makes it.
I don't disagree. What do you guys think of that? Although I think, it's kind of funny having, we have a CHF and COPD, and bi-level is kind of sort of the right answer for both of those. But what do you guys think of that option set?
Are we clear that her medication attacks are accidental?
Well, we kind of went through that of, we're just talking sentences, so it starts in weird, awkwardly.
She's speaking, I guess.
All right, I can tell attention spans are waning. Everybody stand up, walk around, take 5 minutes, go to the bathroom, get a coffee, do the things, and we'll round out another 3 hours of this.
Yeah.
It's hard. Where are you? So easy.
Yeah. Yes.
What is it?
Being difficult back here, Louis. Yeah. Oh, he's a resurrected. I mean, it was a super interesting concept. And somebody actually got that guy Charlin to talk at SAEM like around 2010ish. And it was a really good talk, but I think it just was too. There's a lot of hurdles with it. Yeah. 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 Yeah, no, I think, I mean, this is one of my many soapbox issues is like, I think we do learners a disservice by focusing on this whole like one best answer because like it's so rare in medicine that there's one best answer. So, you know, like learning to appreciate the nuances, like, well, you could do any of these 5 things, and in this particular case, maybe that one's a little better, but really the other 4 would be fine. So, you know, like especially with like new, like I have 2 instruments right now that are like, but what's the right answer? You know, it's like they're all the right answer. Like, no, but what's the right answer? You're like, they're all. It's fine. You can do any of those. Like, yeah, yeah. 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 Sorry.
Intern thinks about and in our department, and 30 minutes later, I see like a CDEM information. They'd be like, well, they like that paragraph appointed by us, but also a paragraph. Right, and his thing is, and barely we're gonna
Overruled. Yeah, it's tough that way. Wow.
Maybe it adds a word each one on there. Really great.
It's worse in our like we have other trades. Like I see some results from one of the sites and they're just like
100%.
that's all the data.
Like just about 100% of our patients are seen by someone.
So site
Yeah.
right now.
Yeah, we have the same product. Ours is not. Ours is probably closer to like 75, but it's still pretty high. But that's like, and whenever I'm working with new interns, they're always like, "Well, I see somebody ordered on like Signor all that. Like, what do you want to do? What would you do? What do you want?" Like, somebody picked in a protocol because at one of our hospitals, that stuff is all actually nurse driven. You know, so it's like I don't know who ordered this stuff. Like, just ignore it and tell me what you want. Yeah. Yeah. But I have also found a lot of like skipping over the assessment part, right? And they're like, okay, here's this person with chest pain, and here's their vitals, and here's their exam, and so I want to get a BMP in a bit, and I'm like, well, what about like, what are you worried about? Like, can we talk about that for just a second?
There's no like, what's different? Just maybe okay, thanks, fine.
Yeah. Kids these days. Yes. It's a good point. It's a really good point, right?
That's the thing, like the same stress.
Just nonstop 6 hours of just sedation.
Yeah, so,
They were interested in.
yeah, so, like, yeah.
They're not
But I guess if you're saying, or you put mile in your hats for the oversight.
And so I appreciate that for their years, and then based on that, we should be doing a little bit and that's the hospital. Expert. And get rather
Which is
but then like over I don't know why they whether that can be a third.
We only have that.
Yeah.
But they are careful to optional rotation this year, at the third year, so that way we can come to see if they like it, so if they do like it.
Wait a minute.
Which I think like makes sense, like more like a shadow rotation, they call it, yeah. For the, yeah, I mean, and that's like, just, I mean, that's what the experience, so like, we have not had any yet, but that is, that's a big, like, coming first. So this way, if they like it, they can schedule it on the start at
Plan to see
We're having just for years.
I know.
to be honest,
That's like, there's no way I Okay. No, I'm interested.
This is the level 2 trauma center. She wasn't making it all day. She was by and two small patients. I don't think it's great. It's they're in the showing.
It's definitely one of the types that the structural and
We have our distribution system. Wow. It's like I learned to yeah.
Just the smart people over. Because I want to be sure it's so it's an easy hotel or where are you in high school? Because we have to get Jersey. And I don't think that.
And what's here.
Well, thanks for being here.
The sausage ain't bad.
Propose a talk at.
Do you agree?
You think like, oh, right, I'm all this question. So we have, you come up with an idea. It's easy to accommodate with a question. It's hard to think of. As a test taker, like, the more that I do this, the more I, like, you can look at the answer set and be like, oh, I see what this person's thinking. And it really doesn't, like, the answer is
Feedback. Like this, based on our students. I've reported information about CDEM for about where they basically about taking student or these feedback that are being evaluated.
What do you think of this one?
Because I've seen a lot of feedback. You know, like,
So where they put it in review all the time.
it's AI.
AI source is possible.
I emailed them, very good.
Uh-huh.
Topic.
So you have real parents. Well, bringing that.
Yeah, it's great. It's a good.
So
Yeah.
you need to have like a where and you don't want to evict someone from other people. So we're working on getting our own AI. One of the, I think Amazon was
Like a you're kind of.
I'm excited.
All right, let's dive back in here. So we have a very similar question next. It's a nice, concise stem. I really like the stem. Pretty clear exacerbation of like a sudden onset CHF pulmonary edema sort of a picture. And now I'm curious, show of hands, who thinks the correct answer is A? Nobody? Nobody thinks that bypass will make this person rapidly better?
Then I'll pick like do this structure where like you do like the vignette first, then the vital signs, and then the exam, or does it keep you mixed up?
No, it should. We'll fix that. It should go story, vitals, exam, right? Sort of like a triage note, essentially. Nobody would pick positive pressure on this guy.
I kind of want to just for the improvement in the patient.
I think positive pressure would help.
What
Yeah.
he thinks what he's feeling, I think BiPAP will make him feel better. So that would be the rapid improvement.
Okay.
That's how that's I think the problem I'm having with just the last line is it improvement in the patient's state like or is it improvement in the patient's state like he is less anxious because he feels better because he's getting smaller? You know what I mean?
Okay.
Did they say the answer was magic?
But yeah, right. So
My experience, the next question is the right answer. That next person is the right answer. But it's not a drip, it's IV nitro given in bolus.
But so is BiPAP wrong?
No.
Is it so wrong that you're off the scale from nitro? Like most of us would probably do both of those simultaneously, right? And so I think that I like this question a lot, but you can't have both of those answers.
Yeah.
Because you're going to have enough good test takers who are picking one or the other that it's going to cause problems, right?
Unless you pick two answers.
Well, if you could pick two answers, then you might pick Lasix and nitrogen.
Yes, with this question though is to like make sure students understand, like, yes, this is all treatment of the CHI exacerbation, but what's there's then the most round. As opposed to, like,
BiPAP works pretty damn quick.
licenses and options, or you can take out that.
Yeah, I kind of agree. I think with that blood pressure, you want the blood pressure to come down, and that's why Hydral is a nice sort of
You could
distraction.
say something like, in addition to starting with non-invasive positive pressure ventilation.
You could do that too.
Following medication.
Yeah.
Okay.
Would give the most rapid improvement in this patient.
And they're all IV medications.
Right. And after something.
Okay. And I think rather than to ask, you know, to cause improvement, like I would just say, which medication you want to start at? What's the first next step in treatment or something like that. So we said we're gonna move the vitals real quick.
Now you're testing their age. Yeah. What? Oh, yeah.
Yeah, but we
You're using it.
I would give this was talking about their blood pressure, and what the upper and take that. But the nurse is like, your blood pressure is really high.
All right, but then we need probably one more answer choice. So what else?
Bumex, the Johnson.
Ooh, Bumex. And then I'm just going to take out the routes here because, yeah. Whoops.
Then you don't have to worry about the whole stuff anymore.
So you probably want to
You can take out the drip.
Yeah, you can remove.
Whoops, you're right. Sorry.
Oh, man.
Because you're right. You could give it sublingual. You could do paste. It would, right? All of the other ones would help. All right, cool. I'm going to skip. We could add that. This is the default next answer choice. So this is a tox question, this next one. And it's nicely written, but I don't know that it's student level.
I would say overdose instead of unconscious. It's not marijuana. You can just take your own. It's intentional.
I think this is too hard. This is the right level.
I think this is a resident level question, but I'm curious what the room thinks. And to Sarah's point, sure, we can change that, but again, I don't want to workshop a question that we're not going to use anyway.
It's kind of hard for us.
Yeah, this is like you've done your tox rotation as a resident level question, in my opinion, but I don't know. Anybody disagree with that? Knowing, okay.
But it's a good question.
It's a great question. Well written. We'll send it to ABEM.
You can rewrite it just for like more understanding of the pharmacology.
Yeah, we could, but I feel like, I mean, the tox that's in the student curriculum, I think, is like classic toxidromes and like, and Tylenol, yeah. So that we don't get that deep into it. You know, but that said, right, they should have encountered some of this as med students in pharmacology, right? But let's move on. All right, here is another interesting one because we don't have a lot of OBE stuff, but I feel like this is sort of classic, one of those classic trauma teachings, classic teaching on OB, right? What are the physiologic changes of pregnancy? It's like almost, I don't know if it's a step 1 level question, but it's definitely a step 2 question.
I think that's first three here. What's the last answer? Is there an answer after D?
No. And D is the correct answer. But I was like, I don't know about this. Like,
B and D are- okay, yeah, B and C.
So they're asking me what's normal in pregnancy and what's not.
yeah. Like, is this something we should be testing? It's kind of sort of part of trauma. No.
This is more of a lead question, just say, like, do you know what the physiological changes are?
Yeah.
Right in the state.
Third trimester, on the other side of the lid.
Why is C wrong?
I don't honestly know. I was like, I'm gonna have to look this up. But the other part of my brain was like, I'm not sure this is a question that should be on this test. But let me just. All right. Does anybody feel strongly it should be on the test? No. Okay. Not even I don't even know who wrote this, but we'll say it was Brooks because he's not here. Brooks. All right. Totally agree with that.
You know, honestly, I agree. That is great. I think these answer choices are not appropriate. Oh, if you want to test out like the eruption.
Eruption. Like, I feel like eruption's a testable
Yeah.
knowledge.
In the vital signs for
Other side.
All right, here was another one that was just kind of like a quick, and I was like, meh, I don't know about this.
Nothing's on the.
Most likely finding.
Well, so you got sudden cardiac syncope during exercise, right? So he's got hokum, is I'm guessing what they're getting at. Some of the people that submitted questions gave like explanations of their answers. Other people were just like, here's the answer. So that's the answer.
During exercise with bodily and I think that's hard for.
All right, nobody thinks that I kind of agree too. But I like the idea, right? Syncope in a young person, an otherwise healthy person, like good idea.
Would a student know that level of
Yeah, I don't. I mean, even I was like, wait, oh, that's hokum. Like, it took me a minute. So,
I think the testable point for this is syncope during exercise and like disposition or follow up. Like that's a good testable knowledge.
yes. Right. So you could put the EKG into the stem and then be like, what does this patient need? You know, like an exercise stress test, an echo. I don't know what else. A bunch of labs, a Holter monitor, maybe something like that. All right, so somebody can rewrite this one. Isn't syncope in the curriculum? Yeah.
Yeah, but I think if it's not, it should be the like syncope with exercise should be like.
Yeah. Yeah. Plus, I feel like that's something like they definitely got in core pediatrics. Like, yeah. 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 And so that kind of gets back into that discussion of like what are from emergency medicine are we testing versus like what emergency things that we hope they learned on other rotations should we be testing? And I think that's a classic, right? Of like you pause on the exercise for a minute. So. All right, we now have a trio of questions that cover the same topic. So this is version A. Right, and notice the very careful wording of the lead-in best elimination strategy, right?
So do you need emergent dialysis or just dialysis?
Oh, that's a great point.
Because you're talking about the strategy.
I'm gonna add Furos.
I mean, yeah, the EKG, but yeah.
Yeah, we'll get there with the EKG because there's a couple other versions of this same exact question. Everybody loves hyperkalemia. But yeah, I agree. I think I would just put in dialysis because I feel like emergent really sort of cues it as like,
Yeah.
right? It's not emergent KX late, but it's emergent dialysis.
But then the question reads, she missed dialysis, what she need dialysis.
Yeah, that's also a great point.
Damn you! Right? So. I can tell you, no nurse will think there's ever such a thing as emergent K excellent, right?
All right, well let's look at version 2 then.
Staff.
Maybe short, 3 or 4 nurses that
All right, so now we got a lady who's got a history of end-stage renal disease. Doesn't say that she missed dialysis, right? You sort of have to maybe imply that. She's volume up, she's wet, right? Here's her hyperkalemic looking EKG. What do you guys think about this version of the question? We like this version better, okay? And then our options are next step in management. And one of the things that NVME stresses is they really try not to have consult be the right answer. So I'll just say that.
I would say you need to eliminate and administer of all the answer choices.
Yeah, since that's all of them.
You wish the calcium first.
I mean, I think with that EKG, right, that's a pretty wide, complex looking QRS. Like we are heading in a bad direction. That's one of the ones that I would actually give calcium for.
Eliminate, administer, and consider, and eliminate B and add synchronized cardio rule. Because they might see wide complex something.
I kind of like that idea. Anybody have it? Whoa, what the heck happened there? Rhino, what are you doing?
But then synchronized cardio version stands out as a non-medicine.
Also true. It's back again. Ceftriaxone.
She's practical, I guess.
Whoops, I hate this keyboard.
No administrator got any.
I also wonder if your EKG rate.
Do we want to keep if patient still urinates? Yeah. What's her blood pressure? Her blood pressure's high. We could put nitro in there. You want to do nitroglycerin instead of that? Or maybe instead of bicarb?
It's a small.
That was quick. That was good. I liked it. Yeah, I think the bicarb is in there because like maybe that's like a TCA looking EKG. That's my only thought on that one. But
I think it's not really a treatment, it's just not the first.
Not eliminated.
It's not the best option.
okay, do we want bicarb in there? Or we're okay with it not being in there. You want to add it as a sixth option or get rid of something else?
I think it's good.
You'd like it like this. Okay.
You're all very good.
Okay, and now version number 3 of this question. Very similar story. But here they kind of tell you missed dialysis, right? I feel like if he's a sickler, maybe we should have some more medicines in there, but...
Or the name of this pain management.
Be rid of this.
We could also get rid of the sickle cell disease.
Yeah, you could.
You want to do that instead?
Yeah.
It's probably easier. 'Cause I don't know that otherwise affects things.
Unless you're giving it some opiates.
All right, so now we got not nearly as bad of an EKG, but certainly still hyperkalemic, right? Got those nice peak T waves. And basically the same set. Does everybody think their students would know that?
No,
I didn't know that.
Okay.
Oh, I had K-Slate earlier, but I was using something K-Slate is old fashioned and now.
Well, we're a locoma shop now, and I kind of agree. When I say look K-Xlate, people look at me side-eyed, like, what are you talking about? So
I love giving heads, so it's like slow burn.
you can just write potassium, Mike.
sodium polystyrene, whatever that is. Although, well, potassium binder, does that Q? I guess you got a bunch of sodium, calcium.
Yeah,
Just leave K-Xlate.
But if they know that that's old fashioned, they're like, I don't know how what we're used to do. They know that that's already
All the toxic games.
Yeah, I mean I think that's probably a good. And as we revamp the curriculum, that's the kind of stuff we should hash out of like, okay, who's using what. Oh, that's always a good point. You know who's a stickler about that kind of stuff is Steve Davis. What is their pulse here? Like in the 40s, huh? What do you want to call that? Like 50? You want to call it 50? 40? That's what I was, yeah. 60? Okay. Like, yeah, I want it to be close. That doesn't have to be exact, but right, I don't want it so low that it's like, oh my God, they're bradycardic.
There's key waves, but is it just a drop deep there? And then I feel like maybe the summer storms start, you shouldn't get calcium and stuff, right?
Yeah, that gets a little pricklier.
Right.
Yeah.
And it's not wide. If the QRS isn't wide, like some people argue you should. I feel like all of us tend.
I feel like there's a lot of people in emergency medicine say that. I have yet to have a nephrologist be like, don't give the calcium.
Yeah.
But
I know of one and he was
what's that?
I know of one and he was old and retarded.
There was a recent study on this, that the calcium probably doesn't do anything. So
When was residency?
yeah.
2013, what was that? 4 years?
Yeah, but that, I mean, that's another question. That's why I sort of like the second version of this question better, because that was very clearly an abnormal EKG. I mean, not that this one isn't, but that one prompted action, I should say. All right, are we happy with this one then? Sounds like it. Cool, cool, cool. All right. Oh, this is a long one. Let me get this all on one page here. I see some heads nodding. I kind of like this question too. Anybody have a problem with this question? Like,
This is a good question, but well, I'm just not a CDEM fan, but like it's not a CDEM curriculum. If I learn it in surgery rotation, so it's variegating by discipline for teaching and run teaching and why are we assessing?
it's a great point.
It definitely is like the step two question.
And that too, this is the surgery question.
Yeah.
I think this is still standard EM, you don't think?
If it's not in our curriculum,
Well, so this is where things get difficult, right? Because you have like shock is in our curriculum.
Yeah.
GI bleeding is in our curriculum. You know, and the way that we have looked at this at NBME is sort of if it's a plausible differential of something on the curriculum, it's probably fair game.
The only reason,
But how far do you take it?
the only reason it's not in the curriculum is because we assume it's already been taught.
Right.
So it is fair game if it's
Yeah.
in their body not.
And so I personally think that we should sort of be tracking that in the blueprint of like how much is like pure, like we know we're teaching this versus like we assume you learned this somewhere else. Like I think we should probably keep an eye on that, but we're not doing that right now. But that's a different question. Anybody have a problem with this question? Anybody like my student wouldn't know this or this isn't fair or no? Okay. The exam is confusing?
It's soft, non-tender, vowel sounds. And then she's in, and then you're in turn fistula, post-op, it means I would expect to have more vowel. I mean, at least mildly tender or, you know, maybe it'll rebound, right? But it's just really tender, so it's really 90%.
I mean, she's how many days post-op?
She's 3 weeks.
Okay. Yeah.
So the
Right, because if she's just pouring blood into her intestine, she shouldn't necessarily be tender. But,
necessarily be tender.
yeah.
So that's why I feel like.
Like, we're getting into real semantics.
So I think the better thing would be to change this into esoteric ischemia.
Well, that's gonna be a whole different question. Right.
Yeah, but I think that that's a better
That's within the curriculum.
in the curriculum.
Okay. I mean, that's part of why I like this because, right, you know, bright red blood and not really an impressive exam like most people do. Yeah, it's mesenteric ischemia.
Right. Like it's a good distraction.
Yeah.
I think it's a good question.
Okay. I think it's a keeper. Sounds like it's a keeper. All right. This is a classic. You've all seen that question a million times.
Is this
I feel like anytime you have the vomiting farmer, you're just like, I know what that is.
Well, honestly, like my shop's in a big city, you don't have to be farmers. So this is screaming.
Karen,
Easy answer question. Easy answer.
This, I think this is in the curriculum, though, right?
Yeah, like one of the classes.
But this is, you know, like every student knows this from like M1 pharmacology, right?
yeah.
Very which student first and why.
I would say it's staying the lead into like what's the most appropriate form of therapy at this time or something.
Yeah.
Yeah, because medications applies to it.
That's a great point, right? Nice little grammatical slip so you can cross A and C and E off automatically because it's plural. So maybe like what pharmacotherapy is indicated at this point in time. And then if you're going to have combinations, I would say let's just have all of the combinations, right? So there should be like physostigmine and pralidoxime, even though you would never do that, just put that on the list so that, right, it's like, do I want one of these or two of these or all of these or none of these? All right. So, something like that, all right? And then it's pralidoxime, physostigmine is the only combo we don't have.
Should it just say what pharmacotherapy is indicated? Well, not that.
Oh, yeah, you're probably right about that. You're going to add that option for us? Okay. Right, because we have 3 option choices. Yeah, so 6. 3 combinatorial is 6. Cool. All right. Here's a lovely one. Ooh. Nice brief stem.
Either you know it or you don't.
It is kind of a you know it or you don't, right?
I got lost.
Oh, no. We said it's fine.
What's that? It's I am. E and him.
Is there like a question? Hey, I've got
Yeah,
three.
right, I know. They just recall them.
This is exactly like.
Okay.
See, we can order the, I have that separately that can include that.
Do people, is this a question for us?
No.
I don't know, I kind of agree. I mean, we're sending hepatitis labs on everybody anyway as part of a public health initiative, so I don't know that my students would even know who to choose to send it on if we had that question. All right. We can do just a couple more and then we'll call it a day.
You have radiographic findings on and then order X-ray.
Yeah, that was my first problem with this one. I was like, okay, either we have the X-ray or we don't. So I think what they're trying to say is there's no fracture, right? And so I love that.
You don't need the X-ray there, that's the option.
Yeah, I don't know who wrote this, but trying to read the question writer's mind, that's my guess. Is they wanted to say there's no fracture, so don't worry about that.
And for C, yeah, get rid of ultrasound.
Differentiate costs. That's the question.
Okay, and that makes that a little bit shorter of an answer choice, which we like.
So if you prescribe NSAIDs for people who can initiate ultrasound, is that differentiating the cost for treating, or will people see it as different?
And is that too similar to D, too, is that Q and ultrasound and
Energy from gout.
So you're treating gout and D. When we're assuming clinically that the patient has gout.
Can we take blood cultures out of B? Anybody have a big problem with that?
Yeah.
I know our orthopedists, if we're talking about septic joint, they would care less about blood cultures, but they definitely want a CRP and a SED rate.
I don't think you have to call that CRP and septic. You're thinking about septic arthritis.
Everybody's cool with that?
How about like ultrasound?
Yeah, actually, I like this option. A lot of students will jump to it, but that doesn't differentiate it at all. It just confirms the infusion.
You want that added as an option F or get rid of one of the existing ones?
I think that D and E are too similar.
We get rid of it.
D and E.
Because D isn't helping you differentiate it, right?
Okay.
Sometimes if your treatment works.
Right, but everything,
Sometimes you got blood.
that's a treatment, and everything else is a diagnostic.
Yeah. Okay, this
Well,
one,
we
you know,
don't really have it, because
Something like that.
This was like every other end. Oh my god, there was
Ooh, MRI.
sounds.
Although atraumatic knee pain, do you think students would bite on MRI for atraumatic?
That's what the patient wants.
Their primary care sent them to the ED first.
No, the urgent care. The urgent
It's urgent care.
So kind of like, right, you have A, which is like not wrong, but certainly not correct. And then, septic joint, aspirate the joint, look for a DVT, look for gout.
Maybe instead of which of the following steps should be taken next, which of the following steps would best differentiate the cause?
Like, which of the most appropriate diagnostic step to confirm your diagnosis?
Yeah, I think I like that. Or determine the diagnosis, confirm the diagnosis.
You gotta make it worse, a little more specific.
And the NBME has a list of like standard lead-ins, and that's one of them. So, all right, well, that was nice and easy to fix. I like it. Oh, these are the ones that I didn't get into. Yeah, this next one was a septic bursitis. I was like, I don't know, is that a thing? Is that a? I feel like that's a resident level thing. All right, so not septic bursitis. We'll skip that one. And then we had this one, which I felt like sort of getting into the different treatments for like a epididymitis or prostatitis or whatever this is maybe beyond student level. I don't know.
Is it just urethritis?
Well, he's got this perennial pain. It's been going on for 3 months. So I think they were trying to get like a sort of a prostatitis sort of picture, but yeah.
I mean, it's kind of not clear what exactly you're treating here.
Yeah. But so even if it was a clear picture of, urethritis, probably like, I don't know if is that a thing that we really expect students to know of, like, oh, this person with this level of infection needs this specific treatment.
Let's take personal.
All right, so we'll skip that one. Acute vision loss. I don't think that's in our curriculum, right? Yeah. Is anybody teaching ophthalmology stuff to their students? I'm just curious now. No? I mean, right? If they pick that patient up clinically, then we're having a conversation about it. But all right. What do you guys think about this one? I was like, I don't think a student really needs to know this. Yeah. All right, I see a lot of heads shaking. What's that? Yeah, right, as opposed to like orthodromic, antidromic. Yeah. That's very like, I could Google this. All right. This one I thought was a okay question, but I thought it was sort of outside of the student realm.
Is this one of the things where you're not supposed to have a not question or no?
Yeah, well, that's right. That's a whole different issue, but yes, correct. But those are usually relatively easy to fix.
This is not.
Yeah, I feel like this to me is like second year resident level.
I don't think you can expect them to know like specifics of innovation outside of communications.
Okay. Kind of agree with that.
I don't know, this novel, it's like shock index. I'm not sure that would be probably the bridge department. Might be like.
Right, resident.
Okay. What do you think about the teaching point though, right? Of like flex triaxon and up, yeah, no, like,
In addition to taking costs in addition,
yeah, yeah.
in addition to considering transfusion or whatever.
I think this might be in there though, in the teaching day, because you just had a Jeopardy. This was on.
There's a GI, right?
And I think the esophageal part with the set tracks and
Right.
it's a teaching point in the curriculum.
I don't know where you're going to do this with. I think their question is hard.
It's hard, but I think
So it sounds like this is at least appropriate content level. I agree with Doug that we should probably say something about like stabilizing the patient. Like, after you do this, what would you do next? So, would people give, say, like octreotide, right?
But
Oh yeah, there we go. I'd like that even better.
all of it.
I was gonna say, you could say consent for transfusion, you know, like getting stuff started.
You can say like GI. The patient goes to the OR and doesn't go to the CDEM. I'm sure on the way to like the OR.
I think that's actually.
Okay, can we think of a fifth option for this one?
Oh, I would not treat that as your
But then isn't that the best answer?
But the next step,
You would get PPI.
I think staff drugs is more important.
I would put like a PPI.
In an actively bleeding patient?
I would put all.
It's the only thing I thought that was still like evidence-based to change morbidity and mortality,
So it's,
right?
Yeah.
it's not.
Only it's embarrassing.
But not only it though, like in PPIs produce transfusion markets. So here's that family test with dead. Oh, I'm
Right.
PPI is a lot.
Yeah, yeah. I mean, they insist on it. Like,
Yeah, if you think it's varicose, that was what I thought, right? Yeah.
That's.
The thing is, like most cardiac bleeds and cirrhotics are actually, or alcoholics are actually, gastric. Like, also
be
gastric. Yeah. So this is very well being also complete, right? You don't know.
Yeah.
So PPI, like patient will get blood, PPI, creatinine, or something.
Yeah, you probably.
Yeah.
I think if you put either PPI or creatine on there and expect them to fix something, some of them will get.
Yeah.
Right.
That's kind of how I feel about it.
Yeah, you just need to know that ceftriaxone is part of the stuff.
Yeah.
And that's not universally.
Yeah.
So bad mistake.
Are you creating this for?
Have people otherwise like this question?
Okay, so do another answer.
I don't know. It's nice to have 5 answers, but not critical. Oh, TXA. That's great. Nice. All right, this one can go back up with the other ones. Let me just. Actually, Deep, would you mind cutting and pasting that one higher up where the other ones don't have numbers? All right. Second trimester bleeding. I don't think that's in our curriculum, but it is a thing that they get on OB. Yeah. That was my other problem was like 15 weeks ectopic. I don't think ectopics ever happen that late, but it's been a minute since I read up on ectopics. I thought you were pretty much dead by 12 weeks. And rare to go past about 8. Yeah, that was like, wait a minute. Okay. We'll skip that one. All right, this one I thought was okay. This is a head trauma patient. The only thing I will say is in our ED, our trauma surgeons like never ever ever want us to give mannitol, because then when their blood pressure drops, they're like, "Is it trauma? Is it mannitol? Oh my God, what are we gonna do? Scan them." So, but I sort of wanted to read the room on that. I don't know if that's like a unique to us or if that's a problem everywhere.
We do hire.
I think that's the trend that's going to, but obviously not every place.
Is there anybody that if we changed mannitol to hypertonic saline would have a problem? Then we will obviously have to get rid of hypos.
Well, they can't fix it.
I think that's what's nice about it is that those are all opposite answer.
And it's most appropriate next step, not the best step, so, but you're not trying to do state of the art here.
Which of the following is the most
Yeah.
appropriate next step?
So I think that's an okay.
You think it's
question.
okay as is? Okay.
Yeah.
I mean, it's isolated head trauma, so it's probably okay, but I just wanted to ask that question because, this is the kind of stuff that like students write in about. They're like, "Rah, rah, rah," so.
Trepanation.
What's that? Well, it's a no because any of them.
You want to go way back?
They try to do that wording very plain.
Okay, that's one.
Yeah.
Have any of the text changed, or is there any actual evidence to suggest that it is no longer represented?
Not that I know of. Again, that's
What, in some places, that's all they have, so.
yeah.
you know,
So
But that's where where I have heard that, because they complain about this when patients get transferred in, is like basically because mannitol is so notoriously leads to hypotension that people are just like, is it the trauma? Is it the mannitol? Now we gotta scan them. Oh my gosh. As if we don't pan scan everything that walks through the door anyway.
As long as it's still
Literally,
there.
it's
What's that?
I feel like that's
console, it's like, next step, that's not the quick event.
That's a great point. That one is really not a good emergent.
I would almost do more something like, do Keppra or something.
Oh, yeah.
Oh, prophylactic Keppra?
Yeah, like, 7 rounds. Yeah.
What's the, how do you spell the generic of Keppra again? Something like that? I don't know. I can't spell that one. Leve?
No, that doesn't work. We'll figure it out.
Whatever that's a Keppra.
We all know what you're talking about.
Thank you. All right, it's getting out of hand here. We're almost done. We know what the wrong answer is now.
Yeah, going back to mannitol.
Uh huh.
Current mannitol, I can't remember these anymore, but it is, that's still taught though, for like step 2. I can just imagine like a step 2 review book saying mannitol still replaceable.
That's a great question.
All the texts are like 3 to 5 years behind anything that's writing up.
But if things are shifting, I mean, that's the problem, is these questions will be on a test for 3 to 5 years. So if things are in the process of shifting, we don't want to have to pull the question
But
later.
the thing is, mannitol, I mean, again, if you do not have hypertonic saline, you use mannitol. Right. So for the purpose of
Right,
this patient,
it's still the best.
it's the best answer. You know, is it the best overall answer? No, but it's the best answer to the question.
Are we still sticking with mannitol, but you don't want to get rid of hypertonic saline, though, but just in there, just hypertonic saline and.
Well, but then you get rid of hypotonic, which is, it's nice because there's 4 things that are the 4 like recommendations, and 3 of them are opposite.
And clearly hypotonic saline is a bad answer.
Yeah.
It causes more problems than, right?
Yeah.
And if you just think,
It's like a
oh, I
whisper.
heard somewhere they do hyper or something saline, and you're guessing, you're gonna guess the wrong answer.
Yeah. Yeah, I like that as a distractor. But I also am sensitive, like I feel like because many of our students are at places that are level 1 trauma centers, right? And so they are hearing from trauma residents, trauma surgeons, emergency physicians, like, don't get mannitol, don't get mannitol. And so for like mannitol, even though it's right in the right situations, I worry that may cause some problems. But.
Anything hold? So no.
And then 5 years from now, they'll be saying, give mannitol.
Well, yeah.
You know, because.
The pendulum goes back.
I mean, I kind of like option A, you know, like if you reverse that, just because it's all bars, and then maybe you don't think about it as well.
That they should raise the head of the like
Yeah.
answer.
Yeah. Instead of all these, you know, thinking on the pharmacology, just like very simply, you'd be great. We had to reword some of this now, but. Or we're making.
Well, but the STEM is more like, you know, this person's herniating right in front of you, what do you have to do right now?
Yeah.
You know, my first thought is not raise the head of the bed, my first thought is give something that's gonna reduce the, you know, swelling. of the
Well,
brain.
and they're headed to CT, so they're going to lay down flat.
Alright.
They don't think it's smart.
Not like we-
CT scanner must be lowered to the bed.
Instead of lowering, we just say, put the head of the bed.
Yeah,
Should that was her decision.
I think it should look just like.
I think I agree with Nate here. I think before the patient gets a CT, I'm not sure if I'm gonna give mannitol. They're headed to CT.
She's got an 8mm pupil.
You can get rid of the patient's head in CT, then the question's fine.
Yeah.
Because I mean, this is an active herniation that you're describing in the STEM. Who's sending their patient to CT? That's what they're trying to fix it.
I mean, that's like a classic epidural story there, but. Should we add in the left pupil to make it obvious that she's got a blown pupil, or that's good enough as is? And your left pupil is 4 and reactive, or right pupil is 8 and minimally reactive, or leave it be? Okay. Oh yeah, is that you guys okay with this? I mean, I don't want to. Okay.
No, I think it's.
Okay. All right, then let's stop there. It's 5:05. Yeah. So did everybody add real quick their emails to the top of this list so I can badger you to write more questions?
Yeah.
Sure, I did.
I didn't.
I mean, so I can enter you in a drawing to win prizes and money. Yeah, up at the very top of this document, there's a QR code. I'll go all the way back up there again. If you need to scan into it and just real quick add your name and email. And then, as Navdeep said, we would love to have people on the CDEM question writing committee to help write stuff for the test. Oh, I can't get that to a point. Come on, you. There we go.
Is there a sign up for that, or is that this list?
That will be this list. We'll put it that way. I think those of you that pre-registered for the workshop, I probably have your name and email somewhere, but just throw it on here that way for sure we have it. All right. Well, I hope the first part of this, for those of you that were here for it, was useful, and I hope going through these as a group was useful and kind of give you some thoughts and tips about things to look for as you write your own questions. And I mean, I've been doing this for probably 15 years at this point, and I'm still working at it. So.